Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. Woo! It is Sunday, June 7th, 2026, and it is time for another live IC support group meeting. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. I work with men and women who have pelvic injuries, bladder stuff, pelvic stuff, muscles, Hunner's lesions, infections, you name it, we work with them. Now, my goal is to give you education, knowledge, support, encouragement. I want to empower you. I want to get you back into your doctor's office, ready to have a really good, productive discussion about what might be happening with you and helping you, most importantly, find the right treatments for your unique case. Now, I am live streaming right now on YouTube and Facebook. I see YouTube is working. Hello, YouTube. I don't know if you're just checking in. Hello, it's Jill from California. Or if you're actually IC patients ready to participate in our meeting, I am not so sure what's happening with Facebook. I cannot tell. Hello, Facebook. Hello, my friends. Hi, Anne. Anne, is the sound okay? My screen has frozen already on Facebook, as it is known to do. Oh, thank you, Susan. Thank you. Okay. Excellent. I have been running this weekend. So yesterday I was out all day doing a big art event. And then this morning I've been installing water in my garden, irrigation systems in my garden. So I just got out of the shower, just dried my hair. So anyway, I am here now. What is happening in the IC world? We are waiting for our Elmeron patient registry survey to be finessed by Emory University so that we can launch that. Our goal here is to expand the... Hello, Susan. Oh, it's another Susan. We got two Susans. Susan says she is pain-free. Pelvic pain therapy. The pelvic pain therapist is wonderful. I have not been bike riding in 3 weeks. I'm in pain-free. Thank you. You are welcome. And I'm so glad you are staying off the dang bicycle. You know, the human body was never designed to sit on a bicycle. And when you're young, your body can adapt. But you know, the challenge with a bicycle, especially a hard bike seat or even a motorcycle, is that, you know, basically you're sitting with your legs spread, you know, and the bike seat is pushing directly up into your tender bits. It's not pushing into bone. It's pushing into pelvic floor muscles. It's pushing into the pudendal nerve. And it takes a toll. It can cause compression injuries. It can cause damage. It can cause neuralgias. Hello, Darla. It's nice to see you too. Hope you're doing well. Tell me how you're doing. So, you know, there was this one really important case. I always, in my brain, I remember important conversations. And there are two very, very important conversations that I remember from men that I will never forget, among many. But for example, back like a couple of years after I started the IC network, I got a phone call and it's like, "Hi, it's Jill. Can I help you?" And it was this gentleman who was sobbing. He was crying like you couldn't stop crying. And I just very gently just kind of whispered to him and talked to him and just try to bring it down a little bit. What he said to me stunned me, because what he said is that I am the chief of one of the biggest trauma units on the West Coast. He's a doctor. And he said, I have IC. I live with pain every day, and I have told no one, because the minute I tell everyone, they will laugh at me and I will lose the reputation I've worked so hard to build. And he just burst into tears again, sobbing again. He said, I can't do it. I can't do it anymore. You know, I'm writing this new pain guide and I'm really enjoying it. Man, I am really bringing in 30 years of experience working with patients into this new pain guide. And it's really driven around patient stories. And, you know, women have very different stories than men. And none is, and of course, they're all valid. It's not like the female experience is better than the male experience, or the male experience is better than the female experience. But this is what I'm going to tell you. Men don't have the support that women have. 100%. 100%. Because you know what? Us girls, we talk about everything. Hey, are you constipated? I am going through the worst constipation right now. You got any tips for me? A girl will have no problem saying that to another girl. A girl would say, you know what, man, the last time I had sex, it was painful. A girl will have no problem saying that to another girl and another family member or friend. But a guy won't. Men are taught and ingrained to take care of it. It is their responsibility to fix whatever the hell is going on. But you know what? They can't fix this. And worse, they are deprived of people that they can talk with. And you know, the other thing here is doctors minimize it too. You'd be amazed at how rude doctors are to other doctors. And doctors are to nurses, and nurses are to doctors. It's like, I don't know, you know, it's so interesting when a doctor goes in to seek care that they're just dismissed. They're dismissed. They can even be told, are you sure you just haven't worked too hard? So anyway, can you imagine the chief of a trauma unit calling me sobbing in pain? And what I did for him, what we did for many, many years on the IC network, is we had a confidential support group for medical care providers, because they were very, very worried about their professional reputation. So they could come into that forum, they could change their name. And I've worked with a lot of doctors and a lot of nurses and a lot of other medical care providers who have this. Okay, so that's like one memorable conversation. The other memorable conversation, getting back to the bike riding thing, was it was actually his elderly mother called me and said, my son is in a lot of pain. Can you help him? And I went, sure, I'd be happy to talk with him. He was 38 years old. And he had just started having symptoms the year earlier. And they were not little symptoms. These were big time IC symptoms, frequency, urgency pain. Of course, men are often assumed to have prostate issues. They're often given antibiotics. They're often given a number of prostate meds. Eventually, he was diagnosed with interstitial cystitis. He was given the IC meds. And over that period of a year, man, he just got worse. He was not responding to anything. So we get on the phone. I start talking with him. And like one of the very first questions I ask is, so are you diet sensitive? He goes, no, I can eat anything. Eating the wrong food doesn't make me go to the bathroom. And it's like, well, isn't that interesting? And then the next question is, when is your pain the worst? Before you pee or after you're done peeing? And his was after he was done peeing. Now, if you've got an injured bladder wall, so here's your injured bladder wall, as it fills with urine, right, gets fuller and fuller, any injuries, urine is going to go into. So most patients who have an injured bladder wall, as their bladder gets fuller and fuller and fuller, they feel worse and worse and worse. And as soon as they pee, they feel better. That tells us it's the bladder wall. But a lot of patients aren't like that. A lot of patients have worse after they're done peeing. And he was one of them. And you know what that means? That means pelvic floor. What that tells me is his bladder wall is pretty good, but it sounds like his pelvic floor is kind of toast here. So then the next question was, what do you do? What do you do? He was an Ironman athlete. He owned a gym, worked out like a beast. You know, and Ironman athletes hit their peak right in their late 30s. He was at the peak of his fitness, and all of a sudden, he was in agony. But then I went, oh, Ironman. How many miles do you ride to train every week on your bike? He goes, 200. And I went, do you know about something called bike rider syndrome? It's like, no. And I explained, well, one of the things that happens when you sit on that bike seat for long periods of time is that bike seat is pushing directly up into your pelvic floor and onto your pudendal nerve. And that's big. That causes injuries. You have a compression injury. Those nerves and those blood vessels and those muscles are being compressed right into a hard bike seat. And there's nothing protecting them because your bones are over in your butt cheeks. They're not in the center. So literally every time you sit, you're pushing right up into your pelvic floor and right up into your nerves. So it sounds like you've got pelvic floor dysfunction. You could have what we call bike rider syndrome. And I've shared that story many times. He got really angry at me. He goes, no, Jill, I'm peeing all the time. That's not it. And he slammed the phone on me. He's like the only person ever in 34 years maybe one other person who slammed the phone on me. And I've only ever had one doctor angry at me in all this time, which I'm really proud of. I really work hard to try to keep everybody happy. Anyway, I was like, okay, I tried. He called me back about a week later, and he was in terrible pain. He said, Jill, I don't know what to do. You're the only one who understands this. What should I do? And I was like, have you had your pelvic floor checked? He goes, no, that's not it. I'm peeing all the time. It's not my muscle. Slammed the phone on me again. Well, you can only try. Called back a third time. This time he was in agony. I mean, beyond agony, like barely able to walk. It's so bad. And I just was like, what do you have to lose? Go get your muscles checked. Please go get your muscles checked. And I explained it again. Listen, you don't have pain as your bladder fills with urine. You can eat anything. That's not what's driving your pain. That tells me your bladder's probably pretty good. It tells me your muscles might be toast. So please go get your muscles checked. And I like begging him on the phone. He's like, no, And then a couple weeks later, he called me back from the parking lot of the physical therapist. And he's like, oh my God, you were right. He said, I have a severe pelvic floor injury. And I was like, okay, this is good. Now we know what we're dealing with. So all those antibiotics, all those IC therapies, all those bladder treatments, pointless at this point in time. We now know that you have got a neuromuscular origin for your pain, and it's time for you to do the physical therapy. I haven't heard from him since then. I am assuming that physical therapy got him better. So that, Susan, that goes back to your comment about now you're pain-free now that you're off your bike. So the hard part there is that, there are people who love riding their bikes. There are people who, I just, if you're an athlete, I'm an athlete. Listen, we do it because it helps us manage our stress. We love being an athlete. I love being an athlete. You take that away from us, that is painful. And we don't know how to compensate for that because this is where we get our stress release. So anyway, my worry is that he probably wasn't going to be able to compete much more with that type of injury. I don't know. And so as Susan says here, she hadn't been riding her bike in 3 weeks and now she is pain-free. And she says, I do love riding my bike. Not sure what I'm going to do now. So you can start with a different bike seat. There are bike seats because the problem with the bike seat is here, hold on. It's the nose of the bike seat, right? It's the because the bike seat's like triangular right there, right? So it's this part, it's the front part of it that pushes directly up in. So you want a bike seat that holds your weight towards the rear of the bike seat. And I have a picture here, right here, and this gives you a good example. So this is called cyclist syndrome, and you can see right here the bike seat pushing up against the nerves, and specifically the clitoral penile branch canal under the pubic arch and the perineal rectal branches. Yeah, okay. So there is a bike seat that consists of two round circles that it protects everything in your crotch. That's the bike seat you would want to go with. And you can do it. I mean, you just have to go try a lot of different bike seats. The other thing you do is you could do a recumbent bike. You can try that. Although, I have pelvic floor dysfunction, not in the center. Mine is more related to my SI joint on my left butt cheek. And I have a pudendal neuralgia on my left butt cheek. So sitting on any bike seat is not, I just am not willing to damage the nerve more. Like I grew up riding horses. My sister had a horse. I love being barn crew. I wasn't that good at it, but I love horse. I love the smell of horses. I love horses. And like there's a part of me just wants to go ride a horse. But it's like, no, I'm not going to risk I already know I have a nerve injury. I'm not going to do it. I'm not going to spread my legs and sit down on something that's hard. I would like to think that I have learned. Because when these nerves are freshly injured, they are really, 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 really painful. So, anyway, all right. So I do think we are looking better on Facebook. Hello, Facebook. Just so you guys know, my screen is frozen on Facebook, but not the comments. I can see the comments, but the screen is frozen, as Facebook is normally does. Loretta says, hello, Loretta. Nice to see you. You're looking great. Question, should PEA 500 be taken with high good fats? Because I take mine at breakfast and I eat oatmeal. What do you say? I'm on it a month and a half dose and notice a difference. Yay. Also want to mention that Christine Whitmore at Virtua in New Jersey has retired. Okay. Good to know. Good to know. So PEA, palmitoyl ethanolamide, is a supplement that helps to calm nerves and reduce pain. And in fact, for that person with bike rider syndrome, we would definitely say, give the PEA a shot for sure. Really well known, very, very effective at reducing a wide variety of pains, from surgical pain, chronic pain, acute pain. The IC study in 2019 showed that 87% of IC patients using it reported a significant progressive reduction in pain over time. It is what I take. There are kind of two schools of thought to this, Loretta. I know that the company that makes Peora, they always suggest taking it with a good fat in the morning, or a good fat, not necessarily in the morning, just to help it absorb. But that's not always possible. When I take my PEA, I take it before I go to bed. And the reason why I take it before I go to bed is because I tend to feel my nerve pain more at night if I'm going to have nerve pain. I had, emphasis on had, small fiber polyneuropathy for many years, where I felt like I was being poked by pins all day and all night. And when the PEA research came out, I'm like, I was barely sleeping some nights. There were some nights I could not sleep at all. And the research came out. I looked at it, to calm nerves down. I knew I had a nerve issue. I decided to give it a shot. And you know what? With PEA, just one a night, my skin is completely normal. And I do not have that pinpricking sensation that I've had for so many years. Yeah, you can take it with food for sure. You can take it with food for sure. Worth talking about Christine Whitmore just a little bit. Christine Whitmore was one of the first doctors who worked with IC 30 years ago, incredibly well known. She's been a speaker for many, many years, did a lot of research, and she has earned a retirement. And so we wish her well in her retirement. I have not heard anything at this point in time about who is replacing Robert Evans yet at Wake Forest. Is taking it on an empty tummy okay? I think so. I mean, I take it before I go to bed. I mean, I'm trying to eat dinner by 6. I'm trying not to eat after that. Easier said than done. Dear Lord, easier said than done. Okay, so I want to share with you. So normally when I do these meetings, I do a little, kind of a little 30-minute intro, and then I take questions. I want to share with you, I read to you a little bit about this new pain guide that I'm writing. And most important, okay. Yeah. Okay, so what I'm trying to do, this is not going to be an academic, what is IC book. Y'all have already read those. We already have those. This is like a nitty gritty, in your face, I'm in pain, what do I do manual. And there are 3 sections: understanding pain, pelvic pain, and bladder pain, preventing pain, and treating pain. And what I'm trying to do is I'm trying to use a lot of patient stories. I have hundreds, if not thousands, of patient stories that can help emphasize some points. So let me just read. I just want to read to you the first portions of the first section that are done now. Okay. And the title of it is why finding the cause matters. For 30 years, I have listened to patients share their IC stories, and one thing has become abundantly clear. We are profoundly different, and so is our pain journey. For some patients, IC begins in childhood, while for many women, symptoms first appear after menopause. Some develop pain during chemotherapy or ketamine use, while many others trace the beginning of their symptoms to injuries, surgeries, infections, childbirth, athletics, or physical trauma. And clear differences can be seen when doctors examine the bladder wall. Some patients have large bleeding wounds that are persistently irritated by urine, while many others, this author included, have perfectly normal bladder walls with no sign of disease or injury. And our pain is remarkably different as well. Some patients experience severe, sharp pain that feels as if their bladder is being cut by a knife, while others describe dull, aching pressure. Some suffer every single day, while others flare once or twice a year. Some have pain when sitting, while others hurt more after exercise or intimacy or stress or eating specific foods. Clearly, we're not all the same, nor do we all have an incurable bladder disease. Leading IC researchers and clinicians around the world now recognize that there are distinct patient groups, each with their own symptom patterns, flare triggers, underlying mechanisms, and treatment needs. The goal is to avoid misdiagnosis and to prevent patients from spending years and often thousands of dollars pursuing treatments that have little chance of addressing the true source of their pain. So the key to successful treatment is not simply managing symptoms, it is identifying the underlying driver of those symptoms. And I'm starting with Jenny's story. Peggy, hold that thought, honey. I'll be right there. Jenny's urinary symptoms and pelvic pain began in her early 20s and were so severe that she could not attend college or work. Diagnosed with IC, she attempted every bladder therapy suggested, yet remained virtually bedbound for a decade. During one of our live ICN support group meetings, like right now, I described pudendal neuralgia and how it typically manifests as pain with sitting that improves with standing. Pudendal neuralgia patients struggle with nerve compression in certain body positions that can be agonizing. And she thought, that's me. She took the information to her urologist, suggesting that she could have pudendal neuralgia, and her doctor agreed. Imaging was ordered, where they discovered that her tailbone had been badly broken and healed incorrectly. She worked with a physical therapist and chiropractor for a year until the tailbone was in the correct position, and to her complete surprise, her bladder symptoms completely resolved. Jenny endured years of bladder therapies that had no chance of helping her pain because her symptoms were being driven by nerves, muscles, and bones rather than the bladder itself. And that is just such a critical concept for you to really absorb here, especially for those patients where you've been on bladder therapies for 5, 10, 15, 20, 30 years ago. And if you stop it, the pain comes right back. Well, okay, then clearly the therapy you're taking is not fixing anything. It's just covering up the symptoms. And we want to do more than that. We want to identify the underlying cause of your pain so that you don't have the symptoms in the first place, right? That makes sense, right? In his groundbreaking book, Breaking Through Chronic Pelvic Pain, A Holistic Approach to Treatment, Dr. Jerome Weiss was blunt in discussing the obstacles that many patients face. He said, quote, pelvic pain is misunderstood. Few physicians have the background to manage pelvic pain effectively, not having been educated to consider the presence of dysfunctional muscles, sensitized injured nerves, biomechanical abnormalities, or severe stress as core contributors to the patient's symptoms. And without an in-depth understanding of the causes, it is difficult, if not impossible, to achieve long-term success. And consider as well how pain is often approached in medicine. Physicians naturally rely on their own training and clinical experience. If they have never personally experienced this type of pain or have not been trained to recognize the many possible causes of pelvic pain, it can be easy to underestimate, misunderstand, or even dismiss a patient's symptoms. The healthcare system itself creates barriers to proper care. Most physicians may have only 10 to 15 minutes with each patient, clearly not enough time to take a thorough history, review prior injuries or trauma, carefully examine the bladder, urethra, pelvic organs, nerves, muscles, and surrounding structures. As a result, treatment recommendations are often based on the assumption that patients have a primary bladder disease. In a worst-case scenario, some doctors turn to surgery, which is often unsuccessful. Dr. Weiss said, quote, physicians inappropriately recommend surgical procedures or drugs when they can't identify the cause of the pain. This is generally because they feel compelled to do something to help the patient who's not responded to therapy. And we have seen this too, particularly in women who have had hysterectomies under the mistaken assumption that their uterus was the source of their pain. One young woman received $1 million settlement after a gynecologist removed her perfectly healthy uterus. Anyway, it's kind of the direction. Then I have Sonia's story. Sonia was in her early 20s when she contacted the ICN, hysterical over the phone. Her pain and urinary symptoms were very, very severe. She was having difficulty getting any doctor to believe her. They suggested that it was all in her head. And, I will confess that when I spoke to her, she was really hysterical. And there was like the little tiny part of me that was wondering, right? When a urologist finally looked inside her bladder after pushing it off for years, they found that her bladder was ruptured and leaking urine into her belly. Sonia had been in a terrible car accident years before, and this injury had been missed by her medical team. And because there was no chance of repairing the damage to her bladder, it was removed. And when it was removed, her pain improved dramatically. Now, granted, this is a very rare and unusual case, but the judgment that she heard from her care providers was not. Absolutely not. And then I talk about some men's issues. I mean, this is just the very, very first section. Beth contacted the ICN after struggling for years with bladder and bowel symptoms, as well as chronic pelvic pain. She shared that all of her adult siblings also had medical problems, including IC, IBS, vulvodynia, migraines, fibro, and anxiety disorder. And each sibling, she had a bunch of siblings. They each had different painful conditions, but they were all part of the chronic overlapping pain syndrome. Beth shared that they grew up in a very violent home where they were abused by alcoholic parents for years. And their story demonstrates how our nervous system responds and adapts to persistent trauma and abuse. Chronic overlapping pain conditions represent an injured central nervous system that functions into adulthood in a constant state of fight or flight. And while bladder therapies might ease urinary symptoms, they will not restore healthy nerve functioning. Her next step was going to be working on some of that trauma. And that's common. It is common when you have one person who has a history of abuse. Generally, all the siblings also have some similar health issues because of that. It's absolutely fascinating. Angie, hold that thought. All right, Peggy says here, I'm on lactoferrin BID for over a year now. I'm nervous about titrating down on them because I'm doing so well on them. Do you have any suggestions? Well, I mean, honey, if you're doing it twice a day, just go to once a day and see how you do. It's fine. You know, somebody once asked Dr. Lowell Parsons, will I have to be on Elmeron for the rest of my life? He said, no, just have to figure out if it's helping you. How do you do that? Just reduce the dose. So just reduce the dose with the lacto and see how you do. Hello, Kayleen. Kayleen says, all of my doctors in Chicago spend 40 minutes to 1 hour for a new patient exam. I feel bad for everyone that isn't lucky like me. Yeah. And, you know, Kayleen, even 40 minutes to 1 hour isn't enough for a complex patient. It's not. You know, because you also have to realize that they're really, you know, a deep dive into history takes time. And I find it so incredibly interesting with some of the patients that I work with, that when we really go back over past traumas, they'll almost all say, I can't remember anything. I don't remember any trauma, any injuries, anything at all like that. And then, you know, about 20, 30 minutes in, they go, oh, wait a second. No, I actually did have a really bad bicycle accident. I really did do something. It's like, okay, there it is. There's that trauma. Angie says, sent you an email about my pulmonary fibrosis and macrobid use. I am floored. Yeah, Angie, I found that absolutely stunning. So macrobid is an antibiotic that you were prescribed for various bladder issues. Weren't you treating at home? Didn't they put you on like long-term macrobid use, just daily, prophylactically? Honey, I don't know if you would give me permission to read your email, but it was fairly important. I mean, well, it wasn't fairly, it was extremely important to you, but might be important for other people to hear your story a little bit. Let me see if I can find it, but I won't do it unless you tell me. Okay. Okay. I've got it right here. So this is Angie's email that she sent me a couple of days ago. Hi, Jill. I had to share this with you. I did come into the live and tell you that I was recently diagnosed with pulmonary fibrosis. I was complaining about the long 6-hour car rides to the Cleveland Clinic and back. But my doctor, the scientific director of the interstitial lung disease department at Cleveland, kept saying that my fibrosis was acting like an allergic reaction to something, that it isn't a normal fibrosis. And while this is very rare, but just my luck, I had to let you know, I had several consecutive months of macrobid, also known as nitrofurantoin, back in 2021. And this is when I developed a nasty, dry, chronic cough. I also had another dose this January. Shortly after, I developed what felt like bronchitis, and my doctor decided to do a lung screening, and that is when the fibrosis was found. They also looked back at all my prior imaging and found that it started in 2021. It's from the macrobid. I thought you'd want to know. It may be something you want to look into and share. I am completely floored by this finding. There's nothing I can do about it. The damage is done. It is not reversible. I just started an antifibrotic medication to slow down the scarring in my lungs, and hopefully that will add some time to my life and keep me off the lung transplant list. But my hope is that you will make people aware that if they are prescribed macrobid often for UTIs, to have their lungs checked regularly. All of this has been a lot, but I'm dealing the best I can. My depression and anxiety is really taking a hit, but it is getting better. I will definitely keep pushing through and doing the best I can. Thank you for all you do. First of all, Angie, oh my God, woman. I wish I could just give you a big giant hug right now. I just want to give you such the biggest giant hug I could. And I'm devastated for you. I'm devastated that you were not educated about this risk. And whose fault is that? Well, in my opinion, that is the fault of the doctor and the fault of the pharmacy, especially when you immediately started having symptoms. You were coughing when you first took it, and yet they missed it completely. You know, I was taking Reglan. So I have, I had gastroparesis pretty bad. Oh, I don't know, like 12 years ago. The gastroparesis is where food sits in your stomach for a long period of time. It's like the nerves in your stomach aren't really working well, so the food just kind of sits in there and ferments. And so you get very gassy and uncomfortable and you start belching a lot. Anyway, my gastroparesis just got worse and worse and worse. And then finally, I couldn't even drink water and I got very, very dehydrated and they had to rush me to the hospital. I had to spend the night in the hospital. So they prescribed a medication called Reglan. And Reglan was great. It was great. My stomach started working again. And then I started having this really weird, after like 2 weeks, vibration or spasm at the base of my tongue. And I started having trouble talking. So I talked to my primary care. They went, you have a tremor. You have essential tremor. It's just a tremor. And it's just getting progressively worse, right? I mean, and I talk for a living. This was devastating. And about 2 weeks later, I talked to my stomach doctor and I said, God, I'm having this really bad problem talking. And he goes, oh my God, stop the medicine immediately. It's from the Reglan. And then he said, let's hope it goes away. because that medication is known for causing permanent problems. And thank God it went away. And so anytime you've started a medication and weird things start happening, man, listen, y'all have the internet at your disposal now. You can immediately just Google the name of the medication, side effects, and especially rare side effects, and see if what you're experiencing is happening. And it's it's heartbreaking that did not happen more with patients who were taking Elmeron in those early days, who were having horrific diarrhea and inflammatory bowel disease. And yet everybody said they had IBS instead of going, maybe this is a side effect to the medication. And now we know that is a horrific side effect to the medication, because it has led to something called polyposis, the uncontrolled growth of polyps in the bowel. And now we have a number of patients who have had portions of their bowel removed, that we now have doctors calling that an Elmeron-associated polyposis. Kayleen here says, Reglan was amazing until you started getting the shakes. Yes. When I was in the hospital, they made me stop. Exact girl. You had the same thing I had. But it was amazing for the constipation too. Yeah. Can you imagine if those shakes had been permanent? Like, holy mother of God. Yikes. Donna says, have I heard of any issues with Wegovy and IC yet? No, I haven't. Okay, hold on a sec. I might have gotten one call from a patient about Wegovy some time ago, like several months ago, but it was very, very minor. Didn't seem like it was a big deal. So as of this point, I do not have any information on Wegovy causing any issues with IC. But you know what? Let's just go ahead. Let's just do it. We're going to Google Wegovy side effects. Let's see what it says. What are the common side effects of, Wegovy side effects are primarily digestive and most pronounced during dose escalation when you are increasing the dose over time, known for causing nausea, vomiting, diarrhea, constipation, and abdominal pain. Some patients have had pancreatitis, gallbladder issues, and now this is concerning kidney issues. That we need to know a little bit more about that. Okay, so what are the common side effects? Mostly nausea, fatigue, headache, dizziness, upset stomach. So what are the serious risks? Pancreatitis, severe unrelenting abdominal pain that radiates to your back, gallbladder problems, and jaundice, kidney problems, severe vomiting and diarrhea that leads to dehydration or a noticeable decrease in urination, severe allergic reactions, and vision changes, particularly in individuals who have type 2 diabetes. Okay, so we need to look at that a little bit more. So now, guys, we got to be a little bit smarter here. How or why would Wegovy affect your vision? Let's see if we can see anything about that. So now you go to the Wegovy main website, you look at the drug information sheet. Cause a lump in the neck, hoarseness, trouble swallowing, shortness of breath, because it's been linked to thyroid cancer and thyroid tumors. Well, holy hell, mother of God. They do not use Wegovy if anybody in your family's had thyroid cancer called medullary thyroid carcinoma, or if you have an endocrine system condition called multiple endocrine neoplasia syndrome type 2. Great. Okay, I want to find the eye stuff. What the hell is that? All they say is changes in vision in people with type 2 diabetes. Tell your healthcare if you have changes in your vision, but they don't explain what that would be. Oh, that's very annoying. All right, hold on a sec. Oh, here we go. Diabetic retinopathy complications. Okay, acute pancreatitis, acute gallbladder disease, hypoglycemia, acute kidney injury due to volume depletion, severe GI, hypersensitivity reactions, diabetic retinopathy complication, heart rate increase, and pulmonary aspiration during general anesthesia or deep sedation. Yikes. All right, hold on a sec. Okay, now, y'all, please do not be offended if I miss your question. Ask it again. Please be the squeaky wheel. All right, I'm going to come back to YouTube here. Dolphin says, my UCLA surgeon wants me to use a vaginal dilator. I had a full pelvic mesh removal. I have very tight pelvic floor muscles. I also have pudendal neuralgia. Do you have an opinion about dilators? Yes, I do. And that is that, God, there's so many different ways I can answer this question. Number one, girl, mesh removal is a bitch. Having a vaginal mesh that, the problem with mesh, polypropylene meshes is many doctors use them to repair rectocele and hernias. In fact, there was just a study that came out a day or two ago about hernia repair and them migrating. What happens is the mesh starts to migrate through structures. So the mesh starts to move. It can move through the vaginal wall. And therefore, when you try to have sex, all of a sudden, the gentleman feels something rough and sharp during intercourse because the mesh has eroded through the vaginal wall. Mesh has been known to go into the urethra. It's been known to sever the urethra. And the fundamental problem with mesh is it's mesh, right? So it's not like it's a solid surface. There's holes everywhere. So tissue goes through the holes. And so it really gets embedded deep in the skin. And removing it is horrific, difficult, very, very difficult. So Dolphin, number one, you did it. Congratulations. You got that stuff out of your body. And I can't even begin to imagine what the recovery was like. I'm so proud of you that you had that done because now at least we can focus on healing. And that ultimately is why when you're thinking about dilation, it's important to the healing process because tight muscles squeeze things. Listen, tight muscles squeeze the urethra. They squeeze the vagina. They squeeze the rectum. Those are your levator ani muscles. They squeeze they squeeze nerves. They squeeze blood vessels. And so now you've had this horrific trauma. You've got scar tissue. You've got pudendal neuralgia, which means you either have scar tissue compressing a nerve or you've got muscles compressing a nerve. You're now in this really complex recovery where we've got to try to get your muscles relaxed and healthy and your nerves calmer again. Like the worst is over. You've had the surgery. Yeah, baby, you've had the surgery. This is great. But now you got to really buckle down and dig in and ask, what can I do to get my muscles as healthy as I can, to get my nerves as healthy as I can? And so Dolphin says here, yes, the mesh eroded into your bladder, into your small intestines, tailbone. The UCLA surgeons shaved your life. They did. They probably did. I remember I was at the American Urology Association conference the first year where they brought mesh research back. And they showed a piece of healthy mesh, which looks like a white window screen. You know, it looks beautiful, sterile. And then they showed mesh that was taken out of somebody's body. And it was black and crumpled. So instead of being flat and clean, it was black and crumpled. And more importantly, as they were trying to understand why so many meshes were failing, they looked at what was growing on the mesh, and there was a ton of bacteria living on that mesh. I mean, that's what I remember. I remember looking at these pictures as I was listening to this lecture at the American Urology Association. It was absolutely heartbreaking. So again, it's really, really great that you had it out. You had a worst case scenario. It eroded into your bladder, into your small intestines, but we're fixed now. Those are fixed now. But now we got to get your muscles healthy and we got to get your nerves healthy. And I think working with a physical therapist to try to release any type, you got to remember that when you're in pain, your body tries to protect you from that pain. And the way that it does that is by tightening muscles. Okay, so you just had a horrifically painful years dealing with the mesh and the mesh migration and ultimately the mesh surgery. So girl, your muscles are probably locked down, tight as a drum. Yeah, tight as a drum. And Dolphin says here, the meth pathology report showed infection, microbiofilm fibrosis. I lived with chronic pain and bladder damage. Yeah. I am horrified that you went through this, but I am so proud that you're here, that you're telling your story and you're working on your recovery now. So I like the idea of physical therapy. But as part of that physical therapy, you really have to work with your doctors and with the physical therapist to try to figure out which nerve is involved in the pudendal neuralgia, where it's involved, and if there's anything we can do to release pressure on that nerve to try to reduce that pudendal neuralgia. We also want to reduce pressure on blood vessels. You know, so working with that physical therapist is going to be, in my opinion, your lifeline. And girl, you're like the perfect candidate for doing PEA, the palmitoyl-ethanolamide. I mean, because it acts by calming nerves down, and you've got massively traumatized nerves right now. So what are you doing for pain? I mean, are you taking anything for pain? I mean, I think putting some PEA on board would be a very interesting experiment to see if that can bring down any residual nerve sensitivity and nerve tenderness. And if you don't know what I'm talking about, it is this PEA. This would be so interesting. And again, as I shared at the start of this meeting, I had horrific small fiber polyneuropathy. And I felt like I was being poked by pins all the time. And this took it away completely. And there were no side effects in the IC study. I mean, this is a stunningly well-tolerated supplement with dozens of research studies showing it effective at acute pain, chronic pain, surgical pain, shingles, fibromyalgia, burning mouth syndrome, chronic prostatitis, interstitial cystitis, chronic pelvic pain, you name it, they've studied it. And the safety profile, pretty much every researcher is amazed at how well it's tolerated. And so I mean, I would do this. Now you're on Lyrica. So listen, the thing you got to understand about the Lyrica and kind of that class of pain meds, and I'm not against pain meds at all. I mean, I chaired the state of California pain conference. I helped promote the governor. I mean, I pushed the Pain Patients Bill of Rights. We got the governor to sign that. I have used opiates myself for especially my first couple of years, very, very successfully. I am all for easing suffering. No doubt about it, because I see patients can suffer. Pelvic pain patients can suffer intensely, as you have suffered. You got to really know your medication, though. Lyrica has something called Lyrica discontinuation syndrome. So what that means is that when you try to get off of it, your body rebels. It's not an addiction. You're not addicted. It is just a drug tolerance. And so you have to go down very, very gradually. You cannot cold turkey Lyrica or Cymbalta. Both of those cause discontinuation syndromes. So when you're at the point where it's ready to reduce your dose, you're going to have to work with your doctor or work with your pharmacist, really create a plan, because it's probably going to take you a couple of months to get down. And again, if you try to cold turkey it, as a couple of my clients have tried to do, I had one client who hallucinated for 6 months, and I don't remember if it was Lyrica or Cymbalta, but the discontinuation syndrome for her was horrific because she didn't stop the medication the correct way. So just have your eyes open about it. I mean, the key point here is that it's addressing your pain, and that's okay. That's okay. But just as we were talking with some of these other medications, you got to understand some of the ripple effects of these meds. And with Lyrica, getting off of it, you just got to go really slow. Okay? Just really slow. All right. Peggy said, I was wondering if maybe we all could do a FaceTime at some point in time. We did this about 2 or 3 years ago when I was at my worst. And it was at that time I knew I was going to get better. Talking with you and others was a wonderful experience. Sometime in the future, guys, I'm happy to go into Zoom anytime. We can go into Zoom in this meeting if you want. We are doing Zoom meetings for our Elmeron group. We don't normally do Zoom meetings here, but if anybody wants to, because I know y'all get tired of hearing me talk. I understand that. It would be nice to hear other people share their story, right? I'm happy to go into Zoom if anybody wants to go into Zoom. You just have to understand that you kind of lose your confidentiality a little bit. So if you don't want people to see your face, then you don't activate your face and you don't have to use your name. But going into Zoom is perfectly fine. I'm happy to do it. She said, maybe before a Sunday session, just listening to you calms me down. Oh, what a compliment. Thank you, Peggy. That means I'm doing my job. You know, bladder pain doesn't scare me at all anymore. Pelvic pain doesn't scare me at all anymore. I'm not afraid of a flare. I don't get worked up about them anymore. I don't have them very often anymore. But I learned early on that with the help of somebody who came and spoke at one of my support group meetings back when we were meeting in person, she said, pain always provokes an emotional response. Always. It's scary. So your heart rate's going to go up. It's upsetting. It's worrisome. And many patients go, oh my God, it's back. Maybe it will never go away. And all of a sudden we are now catastrophizing that, oh my God, my IC is going to be horrific for the rest of my life. Okay, which I used to do too. You know, listen, severe pain causes a severe personal reaction and psychological reaction. Well, she called this the runaway train of emotion. And she said, listen, if you know you're going to ovulate, when you ovulate, you're going to have a flare, and you know that flare is going to last 4 to 6 hours. Is there a reason to get upset about that? Or can maybe you just step off that runaway train and go, you know what? I just ovulated. No biggie. And that really resonated with me. And she said, okay, if you know you're going to flare the day or two before your period, and you know that flare is going to go away as soon as your period starts, do you have to get upset about that? Or can you just go, yeah, my period's going to start? And for me, now that I know that my flares are not bladder wall flares, they're pelvic floor flares, that when I have that flare from sitting too long or being in a car too long, it's like, okay, what kind of flare is it? Pain after urination. Okay, pelvic floor flare. Do I need to get upset about it? Or no, look, you know exactly why this happened. You were in the car for 2 hours yesterday. It's okay. Grab a heating pad, get your dilator, get your wand. You can work on it. You got all the tools to handle this flare. Life will go on. And that just really, really resonated with me. I did really good looking at flares that way. And I really want you to look at a flare that way too. I mean, there are lots of people out there, you know exactly why you flare, because you had that margarita last night. I had somebody who sent me a message who'd had a horrible flare after having a margarita. And it's like, yeah, you had a margarita. Don't get upset about it. You don't need to, slap yourself on the wrist. It's a flare. It's going to get better. It always does. It's really rare that we see flares last in perpetuity, and this is what the research shows. What the research shows is that most patients stabilize in the very first 6 months, and then they just get better. It's really rare that we have a patient who has a steady decline downward. One of the reasons why that might happen, one of the reasons why I've seen that happen, is in patients with Hunner's lesions, which is a big injury to the bladder, big wound in the bladder, who are drinking coffee every day or soda every day. It's like, come on now. If you got a wound on your hand and you pour coffee on it every day, what's going to happen to that wound? Is it going to get better? No. Is it going to get worse? Yes. Are you going to have worse pain? Yes. Are you going to pee more? Yes. And these are patients who literally, they know better. They're doing it themselves, and they're going to have the most steady decline until they have that come to Jesus moment where they go, oh my God, I can't take this anymore. Maybe that coffee isn't worth it. Anyway, Killian says, I got approved by my doctor to do a GLP-1 since the eating disorder hasn't been flaring up, and I've gained 13 pounds. I can't be on it long since I have another bladder Botox coming up around early September. Okay. Kayleen, you better be walking every day. Got to be walking every day. What are you doing to exercise? Angie said, macrobid side effects don't specifically say pulmonary fibrosis. It does say rare effects are lung problems. I just searched macrobid. Incredible, Angie. Donna said, where are the levator ani muscles located? I'm not sure about spelling them. You spelled them correctly. The levator ani muscles are the shallowest muscles directly under the skin. So these are the muscles that wrap around the urethra, the vagina, and the rectum. There are 3 layers of muscles. So you've got, and so think about your finger and where your knuckles are. Deep muscles, middle muscles, shallow muscles. If you're putting your finger in there, about that long. Donna said, finally found a great physical therapist. Keep looking. Took me 3 different physical therapists. Don't give up. Tight pelvic floor muscles are so much better. Someone finally listened to me. Yeah, baby, you did it. Alina says, hi, Jill. I love it when you're on. I've been suffering from IC for approximately 30 years. After several doctors performed several cocktails. In the last 8 years, my husband does the cocktails at home. Lately, I've been suffering from severe vulvodynia One nurse practitioner prescribed a vaginal cream, but the burning I felt in my vagina was horrible. My new doctor prescribed vaginal hormone tablets, which helped for 2 weeks. I'm back in pain, burning knife cutting out the outside of my vagina. Plus, I can't take the pain and the icy pain. Please, please help me. All right, Alina, I got your back, girl. Okay, so we need to know what your IC phenotype is, okay? Because we're not all the same. Understand that, number one. That for some people, IC begins in childhood. For others, it begins after menopause. For some, it begins after having a baby, while for others, it begins while they're going through chemotherapy or they fall on their tailbone. Okay? Lots of different things can affect the bladder. But we don't think of IC as an incurable bladder disease anymore. We think of IC as a pelvic pain syndrome with many potential causes because we now respect this diversity. If you can tell me how old you are, that'd be really great. I would love to know how old you are and how old you were when your symptoms started. So if you've had IC for 30 years, odds are your symptoms started in your 20s, 30s, right? Somewhere in there. All right, Alina, hold tight. Your symptom, honey, how old are you? Okay, now this is great. Okay, so Alina, if you don't mind me using you as an example, she's going to be 74 in July. Her symptoms started 30 years ago in her 40s, but after menopause. Okay, so anytime symptoms begin after menopause, the very first thing we look at is the quality and health of the skin. So, Alina, think about your bladder for a moment. It's the only organ in the human body designed to hold toxic waste, right? Because urine is body waste. Urine contains ammonia and urea and all sorts of bad things. So how can the bladder hold ammonia for hours at a time and not get damaged? It's a real evolutionary marvel because it turns out the way the bladder protects itself is with a really thick coating of mucus. So your bladder is like your mouth. It is a hollow organ that is wet and slippery on the inside. And that mucus plays a really important role in the health of that skin. It's thick, it's robust, it moves urine off of the cells, okay? Mucous membrane organs, your mouth, your vagina, your vulva, your urethra, your bladder, all use mucus to protect the skin. But here's the fundamental challenge. Mucus production is estrogen dependent. So what does that mean? That means that when you're young and have a lot of estrogen, you can make a lot of mucus. But once you're postmenopausal, you don't have a lot of estrogen anymore, which means you don't have a lot of mucus anymore, which means your bladder's ability to defend itself is now greatly compromised. That's not a disease. That is atrophy. That is estrogen atrophy. And so for you, hon, number one, diet's everything. And you say here that you're not doing coffee, soda, lots of water. Okay, but the atrophy isn't just happening internally, it's happening externally. You have severe pain, severe vulvodynia. You've already been diagnosed with atrophy. They already gave you estrogen, and you had the reaction many women have. The estrogen burns like a bitch. Why? Because you're in atrophy. That's why. And the doctors don't take enough time to explain to you that, hey, guess what? The estrogen might burn badly the first couple of times. because the skin has no protections. But that skin immediately absorbs that estrogen and starts to make mucus. They've watched it under an electron microscope. They have, I mean, think about, what does a raisin do when you put a dry raisin in a glass of water? It pulls in the water and plumps up. That's what these dry cells do when you give them estrogen. They pull the estrogen in, they start to plump up, and they start to make mucus. So that burning that you were feeling normally lasts about 2 weeks, but I would expect that every single time you use the estrogen, it's a little bit better. So like the first time that happened to me, it burned for about 5 hours. Second time it happened to me, it burned for about 3 hours. The third time it happened, burned about an hour. Fourth time it happened, it burned about 20 minutes. And now when I use my estrogen, it's like a warm puff of air touching my skin. But if I forget to use my estrogen, the atrophy starts to get worse again and the burning comes back. So it is very, very common to have that symptom. But let me show you a product. Here, hold on a sec. I got to find it. Wait. Hold on. I got something that will help that tremendously. Where did I put it? It's not there. It's not there. It's not there. It's not here. Ah, here it is. It just fell behind. Girl. Alina. This is phenomenal. So this was created exactly for patients just like you. This is an organic olive oil, sea buckthorn, and avocado oil. Okay. And it mimics your normal mucus. It's very light. It's not sticky at all. You can use this every day. You can use it a couple of times a day. Never had a complaint about it because this is not a medicine. It's a slippery coating that will protect that skin from urine as you're peeing. So you can get this right now in the IC Network shop. Just go over to IC Network, click on shop, go into feminine hygiene. You guys, this is my personal bottle. I think I've had this for 2 years, right? And look, half of it's still there. It's $26. Best investment you could make for anybody with vulvodynia. Now, the other thing you should do is, hold on. So I had severe vulvodynia in high school. I felt like I had a yeast infection all the time. And that was because my muscles were very tight. I mean, I had to work on my muscles. I went to a vulvodynia support group meeting, and I was like this kid walking into this room of seasoned women in their 60s, and I was 20. And they took me under their wing, and they explained the importance of a peri bottle. I don't know if you can see this. This is a plastic bottle that has a fountain head. You fill it up with water. You leave it next to your toilet, and every single time you pee, you rinse yourself off. The purpose of this is to get all the chemical residue of urine off of your vulva, and that will massively calm the tissue down. I use this every day for 20 years. Not this, obviously not this one. Every bathroom in my home has these. And everybody who's a member of the IC Network gets a free one. In fact, we just ordered a couple cases. You can buy them in the IC Network shop. They're like $3.99. You know what? They're so cheap. But the cool thing is when you're burning, you can fill it up with cool water. And so this is straight from the women who ran the vulvodynia support group meeting that I went to. This was life-changing for me. And for every woman in my family, we all do this now. And you know, a plain water bottle will work, but what makes this one so good is it has a fountain head, and so the water, you squeeze it and the water just comes straight out, and it's great. Loretta says here, great idea. Can estrogen be compounded with lidocaine? Absolutely. Absolutely. Yes, I had it. I had it mixed. I had pudendal neuralgia that manifested as pinpricks on my vulva. That's exactly what my gynecologist gave me, a compounded jelly of lidocaine and estrogen. Worked so beautifully to get my skin healthy and to calm the nerves down. All right, let me come back to YouTube here. So you guys, for those of you who came in, we're simulcasting. So when I'm looking here, I'm looking at YouTube, and when I'm looking over here, I'm looking at Facebook. So bear with me here. Kelly says, hello, Kelly. Thank you for dropping in. Can kidneys that are not functioning at 100% cause severe urethral pain? I'm explaining my symptoms and my doctor seems to ignore me. I want to call the nephrologist tomorrow and make an appointment. I don't see how they would, honey. I don't, I mean, it doesn't make sense. So when we think about urethral pain, there are several things that we're going to look at, but kidney functioning is not one of them. I mean, the biggest issue might be just that you're peeing massive amounts of urine, large amounts, maybe you're stretching the urethra. That's unlikely. The first thing we're going to look at with urethral pain is estrogen atrophy. So the urethra is kind of the canary in the coal mine when it comes to estrogen atrophy in the urinary tract. And it can really start burning, and it will often feel like there's a drop of urine stuck in your urethra that won't come out. That happened to me when I was 52. And, you know, I mean, guys, listen, my IC self-help skills are obviously very, very good. You know, I wrote the IC network. I am very, very experienced in this. I threw everything I knew at this urethral pain. Nothing stopped it. And it was just getting more and more bothersome. And I finally threw myself on the mercy of my urologist and went in for an appointment. I said, please help me. What is this urethral pain? And he took one look at me and he goes, Jill. And I'm like, I mean, picture it. You know, so I'm laying on my back, my knees are in the stirrups. He's looking down there and I'm looking at him through my knees. You know, I'm like kind of going, okay, what do you see down there, doc? What do you see? And right. And he's like, he was a really great doctor. I loved him. And he goes, Jill. I'm like, oh, what did I do? What did I do? You know, and he goes, didn't you use the hormone cream I prescribed for you last year? And I very meekly went, no. And he said, why? And I said, because in my brain, I'm 25 years old and I can't have an age-related issue. And that's exactly the truth. That's exactly how I felt. And he laughed. He goes, okay, I understand it. And he goes, Jill, this is estrogen atrophy in your urethra. I saw this happening last year. That's why I gave you the prescription. I was trying to prevent you from going through this. And he re-prescribed the estrogen and he had me rub a pea-sized drop of estrogen cream right into the entrance of my urethra. And within 2 weeks, it was gone. Okay. So Kelly here says, urine is very concentrated for hours and burning me. Doesn't matter how much water I drink. I have to wait hours before my kidneys actually make clear urine. Yeah, I mean, I understand that, but you got to understand, but I mean, I'm going to challenge you right back and go, well, if the quality and health of your skin was better, maybe it wouldn't burn you so much. Are we still dealing with atrophy? Because if we're dealing with atrophy, that would be one reason why you're having such a difficult time with this. Quality and health of your skin matters. Listen, if you're over the age of 40 or you've had a total hysterectomy or you've been on Lupron for endo or you're on estrogen mimickers because of breast cancer, listen, you're in atrophy. That's going to directly affect the quality and health of your urethra, 100%. And so if you're, again, if your vulva's dry and your vagina's dry, so is your urethra, so is your bladder. That's the very first thing we're going to think about. The second thing we're going to think about is tight pelvic floor muscles. Your levator ana muscles can squeeze the urethra. So if you are having difficulty starting your urine stream, like you have to hesitate 5, 10, 15, 20 seconds before you can relax enough to release urine. And that's a really sneaky question because the operative word there is relax. If it takes you 5 to 10 seconds to relax to release urine, that points to muscles. Perhaps we're dealing with some tight muscles. We can be dealing with a neuropathy. But, again, Kelly, it's not that your urine's, yes, your urine is concentrated, but if your skin were healthy, you probably wouldn't be feeling urethral pain. I bet you might have some atrophy going on there. How old are you, hon? How old are you? Simon Francis says, I'm having the same problem now in his torture. I feel like I screw up and eat something wrong every day. I had a half a day. I was okay the other day. Does eating sugar cause pain? Sugar promotes inflammation. It's not acidic in the way that like lemonade would be, but sugar is definitely bad. I rarely eat any sugar now. What I didn't know until I had breast cancer 2 years ago is that sugar feeds cancer. And when you think about the foods that are high in sugar, they're often junk foods, Kelly says, I'm using topical estrogen, Vulva Balm, and Reverie. The only thing that relieves the pain is when I can pee clear. Okay. Well, so what that says to me is that the quality of your skin is poor. You're using estrogen. I would have the doctor look at the health of your skin and ask, is that enough? Could you benefit from using a little bit more? Like how often are you using the estrogen? Is it like twice a week? Ask your doctor, again, to look at your skin. And if your skin is still showing severe dryness and atrophy, they might bump you up to every day for a couple of weeks just to kind of really get as much estrogen as they can into that skin to try to help that skin. But it's definitely a skin issue. It's that's being exacerbated by super concentrated urine. And it sounds like it sounds like you're living with very difficult symptoms. Simon says, is it okay to start estradiol after 60? As long as it's the topical, definitely. Definitely. Remember, they just took the black box warning off of all the estrogen products. And the general rule for oral medication is you can do the oral medication up to 45 or start it when you're around 45 to help manage the symptoms of menopause, but they discourage you from using oral medication after the age of 60. But you can use the topical estrogen after the age of 60. Like I use topical estrogen myself. And the topical estrogen is not associated with a greater risk of cancer, which is why they did that. So, and the challenge here is that, I mean, you're just on the aging train like I am. Every day the estrogen levels drop a little bit more and a little bit more and a little bit more, and the atrophy gets a little bit worse, a little bit worse, a little bit worse. So the intention of the topical estrogen is to stop that deterioration of the skin. And the benefit here is the estrogen stays in the skin. It's not distributed to any great degree systemically, which is why they believe that it's far safer than oral estrogen products. Kelly is also diagnosed with your 4th UTI this year, and you're using it every 3 days. Okay, so Kelly, now we have to talk about complex UTIs. If you've had 2 infections in 6 months, 3 infections in a year, you are no longer a simple UTI patient. You are a complex UTI patient. And complex UTI patients need more consideration. We have to step away from guessing and start asking, why is your body more vulnerable to infection, or why is your body having trouble fighting off infection? So I attended a lecture at the National Institutes of Health specifically on complex UTI. And they have studied complex UTI extensively, and they have done daily urine samples and daily vaginal swabs and daily skin swabs, you name it, they've done it. And here's what they found. 24 hours before the bacteria arrived in the bladder, it was living quite happily in the vagina. This then led the researchers to ask, well, wait a second, what's happened to the vagina that's made it a safe haven? I mean, what's going on there? And the answer goes right back to estrogen atrophy. And so complex UTI patients aren't just given the antibiotic. They're usually we also want to make sure they're using that estrogen to improve the quality and health of the skin in the vagina so that that skin can fight off infection. Our job here is to improve the mucosal layer, et cetera, et cetera. So you've been diagnosed with atrophy. They've given you the estrogen. You've had your 4th UTI. Strong suspect is that maybe, just maybe, the estrogen you're using, which is every 3 days, might not be quite enough. And so I think you could reach out to your doctor and say, can you please examine me and let's see where the health of my skin is. And maybe, just maybe, we've fallen a little bit behind with the estrogen. Maybe you need a little bit of a boost to try to improve the health of that skin. Now, the other thing that you could ask for, I have a family member who had many, many legit bladder infections over the years. Like, oh my God, another one. Constant bladder infections, constant sinus infections. And there was real suffering there going on. And they finally figured it out not long ago. Decades she had this. She was diagnosed with a common variable immune disorder. And what that means is that her immune system was not strong. Her immune system was not strong enough to fight off these infections. And when they measured her immunoglobulin G level, she had none. And immunoglobulin G is really kind of your front line of defense for your immune system. She had none. This condition is called CVID. It's not COVID, it's CVID. It's often the result of toxic exposures. It's a toxicity issue. And she and I are both chemists, and she had some pretty significant chemical exposures back when she was in school, just like I did. And so we think now that she's had this immune system dysfunction probably since her 20s. And that would explain the dozens and dozens and dozens of infections. So you could have them do a very quick blood test and check your IgG levels just out of curiosity, because that's treatable with an infusion. Dolphin says, I do the estrogen patch and vaginal estrogen. It has helped me so much preventing UTIs and atrophy. You named it, girl. You named it. All right, let's come back to Facebook. Alina asked, what's the name of this cream again? It is called Vulva Balm, my friend. Vulva Balm. One of our biggest sellers in the IC network. Love this stuff. Alina says, I use the lidocaine gel 5% all the time for infusions and all the vulvodynia pain. My urethra hurts too. Right. Alina says, can you move next door to me? You know, we have got to start. I was thinking about this. Oh, God, the world is such a chaotic place. But, you know, back in the day, we did in-person meetings, IC meetings, like along the West Coast. I had people flying in from I had people flying in from back east to come to IC conferences that we did. The ICA is not really doing any conferences. We haven't really been doing any conferences because of COVID. And I think we're getting close to being time. Unfortunately, the economy is so bad right now. Traveling is going to be a bitch shortly because of the gas prices. So, excuse me for swearing, but it is what it is. Donna says, pea-sized drop of estradiol cream, can you use too much? Yeah, you know, you never use a lot of it. You just do a little bit of it. Pea-sized drop. Jill, Elena says, Jill, are you talking about the skin of the bladder? Yes, the internal inner lining of the bladder wall. I often have UTI. I've even had sepsis. My immune system is low. I have psoriatic arthritis. I've had immune system problems since your teens and 20s. Right. So then, you know, Alina, you could also look at, and for anybody who's struggling with recurring UTI, you can also look at lactoferrin. So lactoferrin is an essential part of our immune system. Here, hold on. My shorts got all weird. We make our own normal human lactoferrin right now. It's in your tears. It's in your vaginal secretions. Lactoferrin is the critical protein that's found in colostrum, which is a critical mother's milk that is given to newborn babies. And the purpose of colostrum and the purpose of that lactoferrin is to build the baby's immune system. So this is a natural antibacterial, antiviral, antifungal. And again, your body makes it. This is normal. This is how the human body immune system works. Lactoferrin plays a very critical role. The challenge here is that our lactoferrins tend to drop, or they can drop as we get older, and for other reasons too. And so there has been quite a lot of research studying the use of cow lactoferrin. Would using cow lactoferrin boost the functioning of our immune system as well? And the answer is yes, it does. And on the front page of the IC network, and let me just go there right now. We have research with recurring UTI. Lactoferrin was found to help prevent recurring UTI, and the IC study was fantastic. Came out 2 years ago. Here, hold on a sec. Let me grab this real quick. So let me read this to you. A new study found that lactoferrin is remarkable remarkably helpful at calming the bladder wall and preventing IC flares. 31 patients with an active history of IC flares in the previous 6 months used lactoferrin for 17 weeks. Out of 31 patients, 28 women experienced no IC flares after treatment, while only 3 experienced 1 flare. And remarkably, there was a significant decrease in inflammatory markers, that's serum IL-6 and D-dimers, that was found with blood testing after treatment. But most intriguing was the improvement of the bladder wall. Both inflammation and Hunner's ulcers appeared to have resolved, and the bladders apparently returned to its normal pink color. Quote, the bladder showed a decrease of inflammation, and the Hunner's lesions appeared to have almost completely disappeared. No side effects were reported. And in 2022, the same research team found that bovine lactoferrin can effectively inhibit cystitis caused by E. coli, making this a viable option for those struggling with recurring E. coli infection. And I have a whole blog on this on the IC Network, on the front page of the IC Network. There are multiple studies that have shown success for a number of different medical conditions. My conclusion was, given the many studies out there proving the role of lactoferrin in our immune system as well as its safety, it made sense to share this with other patients, especially those who struggle with Hunner's lesions. Yes, we would certainly like to see larger studies with IC. And then I have links to this lactoferrin and Sjogren's syndrome. Lactoferrin alleviates chronic low-grade inflammation. Lactoferrin may inhibit the development of cancer via its immunostimulatory and immunomodulatory activities. That is in the International Journal of Oncology, guys. Lactoferrin from bovine milk, a protective companion for life. So I would encourage you to read this article. I think, rule number 1 is kind of do no harm, right? We want to do the easy stuff before we do the hard stuff. All right, hold on a second. Donna said, I watch my diet very carefully. And by the way, we have lidocaine cream in the IC Network store, but I was down to like 3 and I have to reorder. I haven't reordered yet. So if you want the lidocaine cream, get it while you can. Donna said, I watch my diet very carefully. I use estrogen cream 3 times a week, bladder builder twice a day, and finally found a great pelvic floor therapist. Haven't felt this good in a long time. Thanks to you, Jill. Yeah. I love happy stories. This is good. And just think, Donna, estrogen atrophy patients, right? Your doctor said you had an incurable bladder disease. Many patients have been told that they have an incurable bladder disease when there's no disease at all. It's just atrophy. It's just atrophy. And when you realize it's just atrophy and not a disease, it's like, oh, well, isn't that good? It reduces the stress dramatically. Here, hold on. My glasses are being weird. I kind of tweaked my nose here. Okay. Hold on. Get comfortable, Jill. Okay. Angie says, my UTIs keep showing Klebsiella pneumoniae, and my doctors keep saying, where are you getting this? I'm not doing installations or using a catheter. Why is she freaking out? Last August, she put me on the strongest antibiotic she could without putting me on an IV antibiotic. Well, a lot of infections are coming from food now. You got to understand that some of the really severe bladder infections, the drug-resistant infections, they're not because you don't wipe correctly. They're because the meat that you're eating is contaminated. I mean, we're really seeing a reckoning of what mass production is doing to the human body. And so you couldn't pay me to eat, some of these national sausage companies or eat a McDonald's hamburger, because literally you have no clue where the meat came from. Did it come from a factory farm? Yeah, probably. And it's the factory farms that are growing all these super infections because they've got these animals in very small confined places where diseases are very, very easily spread. Cows are meant to be on the range. They're meant to be walking on fields. They're not meant to be put into a paddock where they can barely walk, where diseases spread like a beast. And so the way they prevent these mass infections is by putting them on massive amounts of antibiotics. And so now we've got the perfect environment for superbugs to grow. The more antibiotics you give them, the more drug resistant the E. coli in the cow becomes. Some of them are going to survive all those antibiotics. Then they butcher the cow, they give you the meat, you eat the meat, you eat the super resistant, drug resistant E. coli. And guess what? Now you have super drug resistant E. coli. So I think it's very, very important that you improve the quality of the meat you're eating and not buy any mass market brands. Like when you're at the butcher, you look for a local company. And no fast food anymore. Or deli meat, things like that. You have no idea where that's coming from. It's heartbreaking where we are right now. Alina says, what's bladder builder? My doctor prescribed physical therapy for years, but my insurance refuses to pay. Alina, girl, you and I need to have a long talk. Would you call me this week? We have an 800 number, 800-928-7496. Listen, if your doctor prescribed you physical therapy, that means your muscles are very, very tight. And if they won't pay for physical therapy, that doesn't mean that you don't treat it. You got to learn how to treat it on your own. And if there's any way that you can pay for at least an assessment to go once to a physical therapist, have a proper assessment so that you know the names of the muscles that are tight. And then that physical therapist will give you some exercises that you can do. You can get a wand. You can learn how to use the wand. You can tell the physical therapist, I'm broke. I can't pay for this. I'm coming once, but I can't come back for another year. I have no, and believe me, this is really hitting hard right now with where we are right now. Lots and lots of people can't pay for stuff now. But if there's any way you can go just once and walk out with the name of the muscle, then you can go on over to YouTube and say, and let's just say you have tight levator ani, you can do levator ani relaxation techniques. There are a ton of physical therapists who have videos on YouTube. But the thing is you can't really figure it out on your own at first. You have to have an expert touch your muscles to figure out where the compromise is. It might be on the left side. It might be on the right side. It might be shallow. It might be deep. So the fact that they want you to go to physical therapy and you haven't gone to physical therapy is heartbreaking to me, because physical therapy heals people. Physical therapy healed me. So if money is tight and you got tight pelvic floor, the bulk of your money needs to be targeted at working on those tight muscles rather than taking a bladder therapy that may not have any chance of fixing the underlying problem. Physical therapy fixes the underlying problem. Carla says, can you take lactoferrin and PE together? Sure. They're not the same thing. They operate in very, very different ways. There are no known drug interactions to PEA. The only thing I would just say is maybe take them with a little bit of food. PEA is not really known for causing stomach upset or anything like that. Lactoferrin, some people have a little bit of stomach upset from it, so I would just take it with some food and see how you do. Alina says, yuck, I don't eat meat, but they're killing us with food. They are. And Alina, listen, you call me on the house, you're not going to pay anything to me, girl. Nothing. I want to help you, okay? No worries. All right, let's come back to YouTube. Simon says, home UTI test is positive for leukocytes, but negative for nitrites. When I went in for this in the past, they said it's not a UTI twice last year. Having this again seems to be when spring is. Okay, girl, this is common. So, and I can explain exactly why that happens. So when you do, here, hold on a sec. Let me just grab my sample here. Oh. Okay. So let's look at the UTI test here for a moment. Okay. So here is a dipper. And you can see on a dipper, there are 2 pads, right? And so literally you take it out of the package, you sit on the toilet, or you stand in front of the toilet if you're a guy, you stick it in between your legs and you pee on it. It's that easy. Then you put it aside for 5. How long do they want you to put it aside? 5 minutes? Okay. So let's talk about these strips. The top one is for leukocytes. Leukocytes are white blood cells. They're your body's warriors. They are sent to the area to defeat infection or whatever might go on. The bottom area, and you can see this is a positive, right? That's nitrites or nitrates. No, nitrite. Nitrites are only made by infection. So if you have a double positive, your dipstick turns purple and purple, infection. You take a picture of it, you email your doctor, hey doc, I got a double positive azo, I'm having pretty bad symptoms. Here's a picture. Can you please order up a urine culture for me? I want to run down to the lab and pee in a cup so we can identify what this is. You know, we're kind of long past the days of doctors saying, hey, listen, I'll just put you on a broad spectrum antibiotic. I'll just prescribe it over the phone. Some doctors still do that. The flaw with that is that a lot of infections now are drug resistant and it's a guess. Not that guessing is bad. I mean, but there's no guess here. You have a double positive, you got an infection. The next step is figuring out what the infection is. So normally double positive, call the doctor, go pee in a cup. They might give you an antibiotic afterwards that while they're waiting for the results, and they might change the antibiotic depending upon what the urine culture finds. Okay. But if you're purple up here, but you're normal here, that just means you're positive for leukocytes. So what that means is that your bladder wall is irritated. So think about it this way. Let's just say you are an estrogen atrophy patient or a Hunner's lesion patient, and you drink a soda or a cup of coffee. Okay. So now the irritants in the coffee have gone into the lesion. or they've gone into the bladder wall because of atrophy. Now, your bladder wall it's not passive. Your bladder wall says, help, help, invader, 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 invader. Your bladder wall signals the immune system that it needs help, that there's something wrong. And your immune system then mobilizes the white blood cells to the area to find the invader and kill the invader. Normally, the invader is some sort of infection. Okay, so now we've got white blood cells swarming up into the bladder tissue. But here's what's so interesting about it is the white blood cells arrive in the blood vessels. How do they get to the bladder? They swim through the blood vessels. But when they get actually to the bladder wall, so they've come from another part of your body and they're swimming there, another part of your pelvis, how do they get out of the blood vessel and into the tissue to find the bacteria and kill the bacteria? The blood vessels open. The little microscopic capillaries in the skin just open and release. So when they release the white blood cells to fight the infection, they release red blood cells also. So that's why we're going to see leukocytes in a bladder wall flare, and hematuria, microscopic hematuria, is also often common in somebody with a bladder wall flare. So, listen, having home UTI tests on hand is great. We've all done it. I'm telling you, my first 5 years with IC, I probably had 100 urine tests. I was convinced it was infection because back then we didn't know about the muscles. It's like, hey, man, I'm peeing all the time and it hurts. It's got to be an infection. And you call the doctor, they order the urine culture. It comes back negative over and over and over and over again. And a lot of you just run to the ER. You are so completely convinced that you have infection that you just keep running to the ER. And the ER kept saying, we don't see anything. That's because other things cause flares too, like tight pelvic floor muscles. And one of the things that I did to help you understand where these flares are coming from is our IC 101 flare guide, which talks about a bladder wall flare, a pelvic floor flare, a neuralgia flare, a stress flare, a menstrual flare, a urethral flare, a vulvodynia flare, a rectal flare, a sex flare, and an allergy flare. You mentioned allergies. And the cool thing about this book is, so like on the stress flare, we go through what are the triggers? What are the triggers for the stress flare? And then the rescue plan. What do we do to get yourself out of that flare? And so we don't treat all the flares the same way. Bladder wall flares are treated very, very differently from a pelvic floor flare because the pelvic floor flare is tight muscles. So we have to do things that are going to relax muscles. The bladder wall flare means the bladder wall's been irritated by something, and usually it's something that's provocative and irritating, a chemical. So we're trying to minimize the effects of that with lots of different techniques. So if you're struggling with flares, get the IC 101 flare guide. It's in the IC network, and I think it's also on Amazon now. If you're an ICN member, if you're that $100 member, it's for free on your member page. And then we also have the IC 101 diet guide, which is brand new. Came out like 2 months ago. It's with a much bigger expansion of our diet with lots of articles and suggestions. And we have our new IC 101 food app currently for sale, getting good reviews so far in the Apple store for $4.99, and it will be in the Android store soon. In fact, I just ordered a new Android device, which just came so that I can test it. We will have that up there too. So I'm working hard. And then, of course, I'm working on the new pain guide right now, too. Okay, here, hold on a second. Brandon says, hey, Brandon, how you doing, dude? I feel like bladder installation can be so expensive for something you just pee out at the end. I agree. They are. You know, and that's the entire point of phenotyping now, is we don't want to chase the symptoms, which is what a bladder installation does. We want to find the underlying problem and fix the underlying problem. And again, it's okay to treat the symptoms. If you're in pain, you can treat the symptoms, but you got to be laser focused on cause versus effect. We want to try to understand why the bladder wall is so vulnerable in the first place. It can be because of a chemical injury to the bladder wall, like chemotherapy, ketamine, drinking way too much diet soda or coffee. It can be, for women, estrogen atrophy. But for most of us, it is the result of ischemia or ischemia. And what that means is tight muscles over time restrict blood supply to the bladder wall. And if the bladder is supposed to get 24 or 28 units of blood a day and it's only getting 10 because all the muscles are squeezing the blood vessels, are you going to have a healthy bladder wall? No, there's no way, because it's not getting essential oxygen and nutrition. So patients with pelvic floor tension will have bladder sensitivity, but it's not a chemical irritation. It's just because the bladder is being deprived of good food. And so that patient who's pelvic floor driven, you know, you can do all the bladder installations in the world and you'll not get better, because bladder installations don't fix ischemia or ischemia. Pelvic floor physical therapy does. And in fact, that's the goal of physical therapy, is to relax the muscles, to free up the blood vessels and restore good circulation. And you know, what's crazy is I can remember, like back in 1994, UC Berkeley was doing a study on ischemia in IC. Man, I'm just having this flicker of a memory there. UC Berkeley was doing a couple of studies and then they stopped doing them, and I don't know why. Probably not a lot of money. There wasn't a lot of money in it back then. Alina, 800-928-7496. It ends with a 6, not a 3. Angie said, if it's lidocaine and heparin, it's instant pain relief and coats and protects the bladder wall. In a bladder wall flare, I'd pay a lot to calm it down. Another thing you could do, I mean, this is where aloe can help. You have to remember that 30 years ago, when aloe became popular in the IC world, one of the reasons why it became popular was because we really didn't have anything else other than pre-leaf. And so patients flocked to aloe because it has a soothing effect. But the challenge with aloe is that there's no research showing it's beneficial over the long term to IC or the bladder. And, you know, let me just go check again. Every meeting I go check. They've had 30 years to produce a study that was good enough to be published in a medical journal. All right, so hold on a sec. I'm going to search for interstitial cystitis aloe. Nothing. So now that we have other supplements where there's really good research showing that they can help, the role of aloe has fallen dramatically. But the one good role for aloe is for short-term use during a bladder wall flare. So as Angie said here, if it's lidocaine and heparin, it's instant pain relief and coats the bladder and protects the bladder wall. Well, aloe is, just as aloe is soothing to a sunburn, aloe can be soothing to the bladder during a flare. But I can't in good conscience suggest it for long-term use at all, because there's no published research showing there's any benefit. I can give you published research with chondroitin. I can give you published research with PEA. I can give you published research with quercetin, but there's just nothing supporting the long-term use of aloe in the medical journals. And money's just too tight right now. So Aloe Path, which is the aloe that we sell, combines aloe with PEA. So you get two effects: the soothing effect of aloe on the bladder wall with the PEA's effect of calming the nerves down. So I think the best aloe on the market is Aloe Path, because it has more of a soothing effect to it. Frey says insulation should be covered by insurance. It helps soothe the bladder. I understand too. And I just had somebody, and I haven't had a chance because I try not to work on Saturdays. I have to have a normal non-IC day. Somebody sent me an email where they were doing Elmeron bladder installations, and we now have our first reported case of a patient who developed retinal damage from Elmeron bladder installations. So if you're going to do an installation, stick with the heparin lidocaine. I would be very cautious of using Elmeron in any context at this point in time. Frey says, what is my opinion on InterStim? Well, now, that is a fantastic question. Oh gosh, there's so many different ways. I have a long history with InterStim Frey, so you're hearing me because there's so many things going through my head. I ran here in Northern California the first support group that had the very, very, very first patients who ever had InterStim. So literally from day one of my support career, I worked with InterStim patients. And I'm going to tell you, the early days were brutal, horrific. InterStim today is much, much better than the InterStim of 30 years ago. The boxes were bigger. The leads are more flexible. Back in the day, we had patients in my group who literally, they would have the trial, and as soon as they sat down in the car, the lead was displaced, and it was all for naught. But the biggest problem with InterStim back in the early days was the fact that they didn't use any anesthesia during the trial, and I had patients screaming for their lives having that done. I was a patient at UC San Francisco, and I praise God that I did not end up on the InterStim side. I ended up in the clinic of Dr. Marshall Staller, who saw the horrific things happening to the early InterStim patients. And he went to those doctors and said, guys, you don't have to do surgery to reach these nerves. That nerve runs down the leg, and you can access it at the ankle. You don't have to do surgery at all. You can just use an acupuncture needle, and you can hit that exact nerve and still attach the same generator unit to it. This is called post-tibial nerve stimulation, or the brand name right now is Urgent PC. And in fact, that's the neuromodulation I had done. And I had my first 2 hours without pain at week 4. I had my first day without pain at week 7. I believe that neuromodulation helped break me out of what had been a year-long horrific flare. So how does neuromodulation work? Neuromodulation operates under the assumption that the nervous system is dysfunctional in some way, and that by delivering a mild electronic stimulation to the nervous system, that it kind of re-regulates it or reboots the nervous system. I don't know if they would describe it that way now, but that's the way they described it to me back then. Today, we now have years and years of experience with InterStim. And I will tell you that there are hundreds, if not, there are thousands of severe adverse events reported to the FDA every year about InterStim. The adverse event rate is stunningly high. That patients are getting MRSA infections. The devices are malfunctioning. I have worked with many patients whose devices have malfunctioned. You walk through an electronic security thing and the device turns on and now you're getting shocked. I've worked with patients who every time they had a bowel movement, they were being shocked. With patients where the leads break, where the leads move, where the generator moves, where the generator moves up out of the pocket and is painful. And in fact, just to give you some real-time data here, I'm going to go right now to the MAUD database. That's a medical adverse event database at the FDA. That's where we get all of our data on medical devices. So it's a manufacturer and user facility device experience database, like the old TV show MAUDE, M-A-U-D-E. So I'm going there right now, and I'm going to search the database, and I'm going to search for brand name InterStim. And I'm going to do just May. Well, you know what? Let me go. I'm going to go to January 1st of 2026 to May 31st of 2026. Okay. So let's see how many adverse events have been filed this year so far with InterStim. 500. Oh, here, hold on a second. Whoa. Okay, just on May 29th, it looks like there are 29 adverse events in one day. So let's look at a couple of these. Okay. First one, serious injury. Information was received from a healthcare provider regarding a patient who was implanted with an implantable neurostimulator for gastrointestinal, pelvic floor, and urinary dysfunction, sacral nerve stim. It was reported that the patient fell and one of the leads broke off and migrated. The patient was redirected to their healthcare provider to further address the issue. Okay. It's not the worst I've seen, but listen, if you fall on it, you can break it. It happens. It happens a lot. Let me go to the second one. Serious injury. Information was received from a healthcare provider regarding a patient who was implanted with the implantable stimulator. It was reported that the patient had an InterStim revision for a lead fracture in 2021. The patient was redirected to their healthcare provider to further address the issue. The problem with this database is that, like, it's loaded with stuff from the manufacturer, like Medtronic submits this report to comply with FDA regulations. They've made reasonable efforts to provide as much relevant information as is available to the company. The report does not constitute an admission or conclusion by the FDA, Medtronic, or its employees of the device. Medtronic or the employee caused or contributed to the event described in the report. I'm not particularly convinced that they're giving, there's a lot more to the story than what we see, in other words. All right, let's go to the third one. Serious injury. Information was received from a patient who was implanted with an implantable stimulator for urinary bowel dysfunction. It was reported that they've had some changes in their prostate condition. They think their prostate has grown, so it is not working like it used to. What? Patient said for the first 2 years after getting the device until 2024, they could get up every 4 hours, and that was fine, except a lot of times they still go in between to drain their bladder. They do not use a catheter. Patient said they get up in the morning, it comes out like they were a 14-year-old. When they void, it helps, and 10 to 15 minutes later, they have to go again. Patient mentioned other medical information. Patient said, okay. Anyway, there you go. Here's a malfunction. Overheating of the device. Yikes. Okay, that's a little scary, having a medical device overheat in your body. Information was received. This is also a serious injury, reported April 26th. Information was received from a patient who was implanted for urinary dysfunction. Urgent incontinence was reported. That the reason for the call was the patient reported that they noticed about a month ago their communicator was not working. No lights came on at all, despite several of the cords and outlets, and leaving it unplugged so it could become charged. Patient inspected it during the call and said there was no damage to the port. The issue was not resolved through troubleshooting, offered to replace, and sent a request to repair or replace the device. During the call, the patient said ever since getting the device, it had never helped their symptoms. Patient said they fired their doctor because their doctor talked them into getting the device, and it didn't work, and the doctor had moved the wires twice on it. Patient said it was turned on. They found it was on when they had tested to see what was going on with the bladder, and now they cannot get an MRI because of it. Okay. So the other issue, so InterStim is FDA approved for incontinence and frequency urgency, and so is the ankle stim. Now, the ankle stim has a fraction of the, I mean, they might have one report or two reports a year as compared to hundreds every month. But here's the other thing with InterStim that a lot of people really don't understand. It's that, number one, it's surgical, and it's not just one surgery. It's at least two surgeries. You have to have a surgery to implant the device. If it doesn't work, you have to have the surgery to remove it. If it does work, you're going to have the surgery to implant the generator. If the generator malfunctions, you have to have another surgery to take the generator out and replace the generator. You might have to have another surgery to replace the leads. As that last patient had 2 lead revision surgeries. Who's going to pay for the surgery? It's expensive. So number one, if your doctor is saying they want to do surgery, the very first thing you've got to do is talk to the billing officer. Is it covered? The billing office in the doctor's office. You ask, is it covered? If they say yes, you get it in writing. You get it in writing from them, but don't stop there. Your next step is to call the hospital. Is this covered? Call the billing office. Is this covered by my insurance? And if they say yes, you get that in writing. And then you call the insurance company itself. God forbid it be what's the most hated insurance company? Oh, you know who they are, that everybody's talking about because of all the denials. United Healthcare. Okay. You call the insurance company, you get it in writing that's approved. You don't let them do surgery until you have in writing it is approved. Because guess what? They might deny it and you're in the hole for $75,000 or $80,000 or $100,000. It's happened. It absolutely has happened. And then the other question that you have to ask is, okay, ask your doctor, if I lose my insurance, will you still care for this medical device? And if they say no, your question is going to be, then who will care for it? And if they say, I don't know, you're going to say, that's not good enough for me. Because I will have something in my body that's foreign, that everybody knows has to be monitored consistently. You know, I got a mosquito bite. It's not like you have it done, you never see the doctor again. You're going to go back to the doctor constantly to have it checked and to have it reprogrammed. We have had patients who they lost their health insurance, their doctor fired them, and they had no care for it. And I had one patient whose device was malfunctioning, and her doctor would not see her because she had lost her job and she was on Medi-Cal. And she called me begging for help, and we called the company begging for help. And there's this whole other thing about ownership. Like, who owns it? I think that's an important question, because if you're paying $70,000, do you own it? Because if it malfunctions and you have it removed, wouldn't it be nice to know why it malfunctioned? You know, these devices disappear. Some of them go back to the company. Here, I got to go get some cortisone cream. Hold on a sec. I got a mosquito bite right there. I'll be right back. I hate bug bites. I hate bug bites. I hate bug bites. You see that sucker? It's right there. I walked around the lake at 5 o'clock and the mosquitoes were out. See it? Oh. Life. Okay, so getting back to InterStim. Am I a fan of InterStim? Hell no. Nope. The only context where I think InterStim is really beneficial is if you are incontinent. It is not FDA approved for pain. If you look at the FDA approval, it is specifically excluded from pain. There's some doctors out there who say it's for pain. It's not. It's not. But if you are completely incontinent, bladder or bowel, it's definitely worth a shot. It can be absolutely life-changing. But for bladder stuff, now that we're phenotyping, this really helps us put it in context, because will InterStim help heal a Hunner's lesion? No, because Hunner's lesions have been connected to viruses potentially, right? Okay. Is it going to heal estrogen atrophy? No. Is it going to heal chemical cystitis? No. Is it going to help with pelvic floor dysfunction? Not as much as physical therapy. I'd rather put that $50,000 into a physical therapist than I would this. So, like the role for InterStim now, I think is really tiny, and it's really for people with just fundamental extreme frequency urgency that they think it's coming from dysfunctional nerves. So typically overactive bladder. That's Curtis Nickel in his phenotyping specifically talked about that. There's an article on our website about that. Okay, YouTube has an error, and I don't know what that is. Dolphin says, can strips find blood in urine? No. All right, let me come back to Facebook here. Brandon said, bladder installations don't help and catheters make my urethral pain worse. Well, yeah. I mean, catheters stretch the urethra, so that's very common. But the fact that bladder installations don't help, I mean, that's really meaningful. Like, we call that an anesthetic challenge. Like, if they put lidocaine in your bladder and it does not turn off the pain, that basically means that the pain's not coming from your bladder wall, because lidocaine is an instant numbing agent. So if they put lidocaine in your bladder and it turns off all your pain, okay, we know we're dealing with a bladder wall issue. But if they put lidocaine in your bladder, it does absolutely nothing, then we're looking beyond the bladder as a possible source of that pain. And Brandon said DMSO helps some. Angie said DMSO set her on fire. It's very outdated. DMSO is really very, very outdated now. I'm amazed. I don't even think it would be approved now by the FDA. The data is. I mean, if you had to choose between an installation that's going to hurt you or an installation that's going to make your pain go away, well, literally, this is why lidocaine heparin installations are the most popular bladder treatment around the world now. We just don't do a lot of DMSO anymore because it has side effects. I mean, I did DMSO. And just like learn from my experience. If you're doing a bladder installation, please don't drive home with the bladder installation in your bladder like I did one day with DMSO. Oh my God. Because I got stuck in traffic and my bladder was burning on fire with this chemical in it. Like literally your dwell time is normally 20 minutes, right? So they put the med in your bladder and then you sit in the room for 20 minutes or even in the waiting room for 20 minutes. Go pee it out and then go home. Do not try to drive home with a bladder installation in your bladder. And there's a lot of debate about dwell time. I mean, there are some doctors who say, hold it in there as long as you can. And so like some patients will literally try to hold it in there for hours. And yet what I have seen, I could be wrong, but pretty much in every study I've read that I can remember, the average dwell time is 20 to 30 minutes. Okay, Frey's asking about axonics. Okay, so let me go back, Frey. Let me go back to the MOD database and let's look at axonics. So hold on a sec. All right, hold on a sec. And I would show you my screen, but we're simulcasting and I can only show my screen on Facebook because I'm using streaming software in Facebook. If I did that, people on YouTube wouldn't see it. But I'm happy to do that if you want to see it. Okay, I've done that many times. Axonics. Okay, so let's just see axonics, and I'm going to do January 1st, 2026 to May 31st. Okay, let's see what comes. Oh, here, hold on. My typo, my spell checker changed the name. 315. There were 4 reports on May 28th. There were 5 reports on May 26th. Let's look at a couple of these. First one, serious injury. It was reported that the patient was experiencing a painful and uncomfortable shocking sensation, both when their device was on and off. An impedance check was performed, but the results were normal. An X-ray took place to assess. The patient later underwent a system replacement. The patient was doing well after the procedure. That is not uncommon for both devices to have that shocking sensation if the device malfunctioned. All right, we're going to the second axonics, serious injury. It was reported that the patient with this neurostimulator had surgery to explant it and the lead due to insufficient therapy. After reprogramming attempts, the patients decided they wanted to remove the device. The patient said they were not getting any symptom relief, but there were no complications reported after the surgery. I don't know why they called that serious injury. Okay, but that was somebody, it just didn't work, so they had it removed. All right, here's another one. Serious injury. It was reported that the patient with this implantable neurostimulator contacted the clinic expressing frustration with the need for frequent charging and lack of therapeutic improvement. The patient reported that the therapy had not provided sustained benefit, despite multiple reprogramming attempts. At the time of the evaluation, the patient was on program 1/2 and reported perceiving prostimulation bilaterally. Due to continued lack of perceived benefit, they had the device removed. Okay. So again, this is really understandable when you consider the concept of phenotyping. Is a neuromodulator going to help a Hunner's lesion? No. Is it going to help estrogen atrophy? No. Is it going to help phenotype number 5, widespread pain? No, it's not. Its best patient community are the patients with severe overactive bladder without any of the other things going on. Okay, Brandon, does pelvic floor physical therapy even help men? Oh my God, yes, absolutely. I feel like I'm too complex. No, you're never too complex to treat. Brandon, here, hold on a sec, dude. I got something for you. Hold on. There is a fantastic, one of the biggest pelvic pain and the most experienced pelvic pain physical therapists that I've worked with from day one. They're called the Pelvic Health and Rehabilitation Center. And their website's pelvicpainrehab.com. And they have a ton of blogs about men and men who have gone through physical therapy. And I'm going to give you this link because I want you to read these blogs, and you will see many men who have responded very, very well to physical therapy. How Chris conquered chronic pelvic pain syndrome. You know what? I'm just going to read this. You guys, just hold tight. I'm just going to read this. This was published last year. At Pelvic Health Rehabilitation Center, we're no strangers to working with male pelvic pain patients. About 50% of our caseload can be made up of male pelvic pain diagnoses. Research shows that up to 16% of men suffer from chronic pelvic pain syndrome at some point in their life. Physical therapy is an integral part of treating it, yet many people do not realize this. Here is a success story and overview of how physical therapy helped a male patient overcome CPPS. Chris is a 32-year-old who was referred by a local urologist because he had painful urination, urinary urgency, frequency, pelvic pain with sitting, and pain with intimacy. He reported that he had dealt with symptoms for a year. Chris is a pilot, and long trips, multiple days per week, required him to sit with this discomfort. I also have worked with pilots, a number of airline pilots, like major airline pilots, as a matter of fact. He had seen multiple providers, taking antibiotics, had many tests performed, including ultrasound, CT scans that were all normal. He began eliminating bladder irritants like spicy foods. As he noticed these substances increased his urinary urgency frequency. He tried eliminating coffee. However, this was challenging to exclude from his daily routine and schedule, and he observed that it was associated with the urinary symptoms. Prior to coming to physical therapy, he was using a cushion while sitting and had been doing pelvic floor stretches, which helped jumpstart his journey towards healing. Here's what they found. Gluteal hip rotator and rectus abdominis trigger points, reduced hip mobility and gluteal strength. Obturator internus palpation reproduced the pain he felt with sexual function. Severe pelvic floor muscle tension at the urogenital triangle. Pain at the perineal body with palpation, which is right above the perineum. One of my favorite things is I used to have that. Assessment. I suspected, due to Chris's sedentary lifestyle as a pilot, that the constant compression on the pelvic floor muscles were causing tension and a reduction in blood flow to the area, resulting in pelvic pain, pelvic floor muscle dysfunction. Hello, ischemia, my friends. The pelvic floor muscles, more specifically the muscles of the urogenital triangle, attached to the perineal body where they cause perineal pain, and I suspect it is painful sitting. The severe tension found in these muscles were contributing to his urinary symptoms, painful sitting, and pain. So what was his treatment plan? Connective tissue and soft tissue mobilization, myofascial trigger point release of the external pelvic girdle muscles and pelvic floor muscles to address the dysfunction. It also included neuromuscular re-education to improve flexibility and coordination of the muscles and a therapeutic exercise, home exercise program. Okay, at 4 weeks, he had less pain with sexual function and was feeling more normal sitting for prolonged flights. At 8 weeks, he was having 85% less pain with sexual function. He was staying consistent with his home exercises. Even while traveling, he reported that his urgency and frequency continued to act up when consuming caffeine. Now, caffeine is a diuretic that can cause the body to make more urine. We discussed how he could still have a cup of coffee while staying hydrated to help urgency frequency. Okay, by 12 weeks, he was able to return to his regular exercise routine. And anyway, there you go. There are case after case after case after case of patients that are shared on this website. So I'm going to give you this link, Brandon. And I want you to just go through them, my friend. Gain confidence because it is helping. Listen, I was working with a Denver Bronco football player who had this. I sent him to physical therapy. It happens. And you know what? It was his own physical therapist who found the pelvic floor tension on the team. All right. Okay. You guys on YouTube, you've gotten a little quiet. Let me go back to Facebook here. Anne says, my friend cannot get rid of Klebsiella pneumoniae. Any feedback? I would do lactoferrin. I'm pretty sure I looked that up and lactoferrin was found helpful for Klebsiella, boosting your body's ability to kill a Klebsiella. Alina said, I have an axonics inserted into my butt, implanted 4 years ago to help you pee. Okay. Frey said, insurance covers surgery. Angie said, used to do installations at home, haven't in over a year. Frey said, what's my opinion on Botox? I had it 3 months ago. It caused excruciating pain on peeing, which I didn't have before. Well, again, Frey, it's about your phenotype. We have to know what your underlying phenotype is. That would help us understand why you're having the reactions that you're having. Hunner's lesions, bladder wall driven, pelvic floor driven, pudendal neuralgia, or widespread pain. You can call me this week. I'd be happy to go through them and see if I can give you some, ask you some questions that will help us try to identify what your phenotype is. Bladder Botox involves injections into the bladder wall. Sometimes it's a bit of a guesswork because, nerves are generally in the same area, but they can be very squiggly. They can kind of be wispy. And so they will do a lot of little injections to try to find the nerve, but sometimes they can irritate the nerve. Sometimes, they can turn off the nerve that helps you urinate and you have to self-catheterize. So the role of Botox has also gotten quite small in the ICU world now that we're phenotyping. I think a better role for Botox is in the pelvic floor muscles rather than the bladder wall directly. Alina said, my bladder installation comes out when I stand up. Doctor told me to lie down for 2 hours. It alleviates, but it's inconvenient. But Alina, that's weird that you can't hold. I mean, are you just incontinent in general? I mean, I've probably had a dozen bladder installations over my lifetime. They never just spontaneously drained out. That's unusual. I would want to know why. We all have our own funky responses. Here, I got to go get, I'm talking a lot. I got to go get some more water. All right, I'll be right back. Let's do a quick bio break. Anybody need to go to the bathroom? Do it right now. All righty then. All right, guys. Tell me one thing you did this weekend that made you happy. One thing that you did this weekend that made you happy. I'll tell you what I did. I love art events. And so we had something called art at the something. And artists around the country opened up their studios. You could just drive around and go see their art and talk to them. And it's just so fun. I did it all day yesterday. I left at 10, didn't get back until 5. I think I drove 40 miles yesterday. You gotta do things that bring you joy. And that's hard when you've got a tender bladder. I understand that. All right. Let me go back to, hold on a sec. So when we started this meeting, I was sharing this new sections of this new pain book that I'm writing on IC, and I'm sharing a lot of case studies, and I want to hear your case studies. Alina says, my husband turned 80 years old. We reunited with his family and we had a wonderful time. Hey, love it. I was caring for my elderly parents for many years. In fact, it was very common for my dad or my mom to just walk in the middle of a meeting. If you go back 4 years, you'll see them. They came in all the time. My dad made it to 100. And my mom made it to 94. And they were all there, But celebrating that 100th birthday, whoo, that was so important to me. And a ton of patience. My goal was to have 100 birthday cards. And several of our IC friends sent birthday cards for his 100th birthday. And that was I'm so grateful. That was his last birthday. He finally, his birthday was November 11th, and he passed away on May 12th the following year. Yeah. Finally had a heart attack. He was having this, he was as strong as a horse, going up and down the stairs all the time. The only problem was his stomach. And his stomach had been a problem for years. He had always had stomach pain. So he was like the king of Mylanta, and it's just, his doctor kept saying it's GERD, it's GERD, it's GERD, it's GERD, right? And so they never investigated more fully. They just, by the time he was 70, he had persistent stomach stuff. So they just said, Jack, it's just GERD. And then he'd have periods when it got worse and to go to the doctor, and he wouldn't do anything the doctor told him to do, which was very frustrating and very annoying. And finally, like 2 weeks before he passed away, I heard him screaming in the bathroom. And it's like, open up the door. What's wrong? It's like, oh, it's my stomach. It's my stomach. It's really bad. It's really bad. So we called an ambulance, got him to the hospital. And, the doctor asked him how he was. He said, well, I'm fine until somebody sticks a sword in my stomach. That's how it felt. And so he was literally screaming in the ER, and they admitted him overnight. He was wailing. It was so bad. He called me, bring my stomach stuff. They won't give me anything. Bring my stomach stuff. Oh, heartbreaking. And I had to beg the doctor to look in his stomach. I said, the doctor was just going to discharge him. And I very respectfully said, he's screaming right now up on the ward. You're not going to send him home screaming. You're going to figure out what the hell's wrong. And the doctor didn't realize that he was screaming. It's like, yes, he's screaming. He's wailing right now. I'm not bringing him home this way. And they said, well, he might not survive the test. And so you got to talk to your family. And so I talked to the family, and everybody agreed. No, listen, he has no quality of life. He's screaming. You've got to look. And what they found was shocking. He had a totally normal stomach and esophagus. He had no GERD. He had never had GERD. He had a hernia, a very large hernia at the top of his stomach. All this time, decades in pain for something they could have fixed. If they had had the decency to look when he was in his 60s, they could have fixed it in his 60s. And so they call me from the OR. Oh, it's a hernia. I'm like, great. Can you fix it? They went, no. No, we can't fix it. He's too old. And when they discharged him, he had a heart attack. They brought him home. He had already had the heart attack. They didn't even know it. And we sent him back. He woke up the next morning. He asked me how to teach him to breathe again because he couldn't breathe. It's like, okay, 911, ambulance takes him back, and he'd had a massive heart attack. Unsurvivable heart attack. But here's the thing. I don't regret the decisions I made. I made every medical decision for them at the end of their life. My siblings were not involved. I made the decision to turn off the pacemaker. I made the decision for palliative care because I was here watching it. And, and he was just like, Jack, his name was Jack. My name was Jill. We were a mixed doubles tennis team, and we were awesome. We won a bunch of tournaments, Jack and Jill Osborne. And I love my father dearly. And I feel him right now, actually. I totally feel him right now, which is crazy. Would he have lived longer if we hadn't requested the stomach thing? Yeah, maybe, but he would have been in agony. The hard part was having to come home and tell his wife, my mother, that it was unsurvivable. And she said, I mean, like, when they told him it was not survival, he's like, hey, I've had a great life. Man, he took it so well. I was just stunned. I mean, he had memorized a poem that talked about, you know, a life well lived, something like that. He was like, okay, it's my time. I'm good. So we come back and we tell my mom, and my mom was like the World War II vet. It's like, okay, he's had a good life. I just want to be with him. I just want to be with him. The problem is she was very frail. I mean, we're talking inch steps with a walker. And I could not get her there easily. You know, I mean, she could, her little legs were like shaking walking in the walker. You know, I thought we were going to lose her much more quickly than my dad ever would. And so I took videos of them talking to each other, you know, so they could talk to each other, but I couldn't get her down there. Well, damn it, she knew what she wanted. And 2 days later, she collapsed in my arm with a massive stroke. 2 mornings later. In that room right there. And he was in his last 12 hours of life. She collapses in my arms. We call 911. We get down to the ER, and the doctors are like, you know what this is, don't you? And we're like, no, because this is broken heart syndrome. She's going with him. She's not staying. She's going. And I hadn't heard of broken heart syndrome, but it totally made sense to me. And, you know, like they had just celebrated their 75th wedding anniversary. This is not a sad story. This is a happy ending for a long and glorious life together, filled with love. They were so loving to each other. And it was my honor to witness that love and to experience that love. And I can't be sad over the way that they went. I am only sad that I had to tell my mother that he had passed away. That was the single worst moment of my life. You know, they were in the same hospital room. I mean, they got her up into the room that he was in the palliative care unit, and we thought she was in a coma. I mean, she was there when he died. We were there when he died at 1 a.m, and she was asleep. And then the next morning, she was barely awake, and she knew she was there with him, but she looked and she couldn't see the bed. Where's Jack? I can't see Jack because the bed was gone. Oh, that was hard. That was hard. And then as soon as I told her, she had another stroke, like right in front of me. Like she's going with him. There is just no doubt about that. Alina says, I deeply believe in broken heart syndrome. Oh yeah, man, it is real. It is real. And you know, it's just, if there's just one thing I would say about my experience with elder care, here, hold on a sec. My computer's being weird. It's that they are forgotten by the family. Please don't let your elders be forgotten. Please, please, please. They are at home right now, desperate to hear from you and to be included. Even if they can't hear over the phone and you have to yell, tell them that you love them. My mother was a love bug. I never heard a bad word about anybody, ever. She's such a better woman than I am in that respect, because I speak my mind. And all the people she helped, all the grandkids, didn't even send her a birthday card. And it just broke my heart. And I'm still angry about it. Like, I'm still kind of angry. Although she's telling me right now, stop it. You don't need to be angry over it. I'm fine. Okay. But please, please, please just know that your grandmas and your great grandmas who are home alone, even if they're with each other, they're lonely. They're tired of watching TV. They just want to be included. They just want to be included. And so call them every week. Call them every week. 4. Alina, 4. I think one grandkid sent over flowers. The only card came from my best friend. So that's like the biggest part of this whole thing is just my mother sitting there wondering why they weren't calling. And I just didn't have an answer. And she would just say, they're busy. I don't want to be a bother. But, she was a really good grandmother. Like, she volunteered at all their schools. Always said, so just please, 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 I beg of you, call the elderly aunt who doesn't have children, me. Call them. Call them. It's like once you're over 60, you're pushed aside by everybody else. And it's heartbreaking. It's just heartbreaking to see and to experience, it is what it is. So, all right. Okay. So I don't know what happened to the chat on YouTube, but it says there's an error. You can try again. Alina says, I have grandkids and great grandkids and they keep me alive. Yeah. You're welcome, Alina. It's just part of my life. I spent a lot of time, I had breast cancer 2 years ago, so that really reoriented my entire life in a way, to go through that horrific scare of cancer. And it really makes you realize that life is short, and you want to leave a legacy. And I don't have children. I couldn't have children. So my legacy is my work, like here, doing this work, hoping that I'm helping at least one person. If I can help at least one person in any given day, then it's a good day, my friends. So, all right, we've been going for about 3 hours now. And I think we're kind of at the natural end. Y'all have kind of slowed down a little bit. So let me just do a last call for questions. Last call for questions. So this week we'll be launching our our Android app. I hopefully I will have a good chunk of the pain report done. We've got new videos to upload if we can ever find the time to do them. We're having a big international IC event. Yeah, there's just stuff. There's stuff happening. Lots of good stuff happening right now. I'm going to say this though. For those of you who stuck around this whole time, thank you. Thank you for listening and you know, I'm here for you, and I just sincerely believe that everybody deserves a helping hand. I mean, I had no help my first couple of years. I had no support. I was very depressed, very frustrated. I felt like my life was over, and it wasn't. I had a doctor say to me, you know, you will forever be a burden on your family. This is your life. Get used to it. Well, I proved him wrong. I mean, that moment changed my life, because that was the moment I went home. I will prove you wrong. And I came home and I started studying, and the IC network is the reflection of the studying that I've been doing for the last 34 years. And believe me, I study every day. I try to look at everything. So this is what we do. Now, here's the thing. Let me just get a little controversial here for a moment. I don't beg away from controversy. You know, I built the first website on IC ever, the IC network. I started the first urology support groups ever on America Online and CompuServe. My co-leader started the IC group, and I helped run that group. Her name was Nancy, because I was running all the other groups. We did the first news groups. We did all the first. Had the first support forum, had the first live support groups, first internet events on IC. I had 100 people in my guest lecture series back then, before we had access to video. And the internet back then was perfect in that it was a safe place where we could exchange information and like genuinely support and encourage each other. The internet today is not that same internet. It's not. The internet today is poison. Social media is, in my opinion, even though some of you are watching this on social media, I want you to understand that you cannot get all of your IC information on social media, because it doesn't allow us to present it. You know, and I've had people say to me, they won't read anything on our website anymore. They want video. And it's like, fine, I'll give you video. And they go, well, no, we don't want to watch that video. We want a 3-minute funny video. It's like, no. This is serious. You're in pain. I'm not going to make fun of your pain. We are going to help you understand why you're in pain and what your treatment options are. And it's getting harder and harder and harder to educate people, because now people are going to effing TikTok for IC information. Are you kidding me? Come on. And yes, I have videos on TikTok too, but we can't do you a good service with short form video. And the problem with short form video is the more you watch, the less you want to read. And then the less you want to read, the less you learn. And it's breaking my heart in a way, because for this current generation, I see stuff online is really badly compromised. For 20 years ago, man, we were on it, baby. We were on it. I mean, the IC network has been rated in 2 huge medical studies. It's the best on the web, the most accurate and reliable on the web. Harvard University, University of London. And yet people don't want to read that anymore. They want to come watch a funny video. And then, so I come in survey groups every now and then, because a lot of people email me and they're like, hey, there's a suicidal patient here. Can you help them? Hey, there's a suicidal patient there. Can you help them? Hey, here's somebody who's struggling. Can you help them? And I've had lots of requests for that. And it's like, listen, whoever started that group, their responsibility is to moderate that group. It's not mine. I don't have all the time to do that. We would like to think that some of these people who started groups online have a little bit of training and at least some ethics, right? Oh my God. Last week, I couldn't believe what I was reading. And like there's one group in particular, it's not on Facebook, that I always thought was one of the best. Oh my, I was horrified. The patient's saying, I want to unalive myself, and nobody responded. Like, what the do you care that there are people right now in your group who are having very, very dark thoughts and they need help and you're doing nothing for them? Then why the hell do you even have a group? Step down. Shut it down. You cannot leave a patient hanging like that. You have to help them. And I'm sorry, I'm pissed off by what I'm reading now. Now, listen, you got to understand. For 30 years, I've answered questions. Our forum was the biggest forum online with almost 1 million posts. Believe me, I've answered tons of thousands of questions over the year. I don't want to do that anymore, which is why our forum's gone. I mean, we have a copy of it, but it's like, I built a website, read the website. It's very hard for me to, somebody saying, what foods can I eat? It's like, honey, go here. There's a whole page that describes it. I don't want to do that, fill my day with answering the same questions over and over again, which is why we have videos and which is why we have a website. But I do not believe that these groups are safe anymore. I just don't. And those group leaders, you can tell the group leaders who've led groups for like 10 years, man, they're burnt out. I know that because I'm 30 years and I've burnt out. And so what I would say to you is, if you're having a rough IC day, don't go into any online support group and expect that you're going to feel better. Number one, you can't put apples, oranges, and bananas in the same group and expect success. The fundamental flaw with online groups right now is you can't expect a patient with Hunner's lesion to provide the right information to a patient with estrogen atrophy, to provide the right information to a patient with pelvic floor, pudendal neuralgia, or widespread pain. And I've gone to some of these groups and I've said, listen, would you please put as a memorized memo at the top, phenotyping? You guys, the secret to understanding your unique case is to start with your phenotype. I said, you don't have to point it to the IC network. I don't expect that of anybody. You can copy anything on my website. You don't have to give me credit for anything. Just get it out there so that patients are not being frightened by other patients, because that patient who has severe Hunner's lesions, who've been drinking coffee for 30 freaking years, who have the bladder the size of a walnut, are going to scare the hell out of a patient who has a tailbone injury, who has a perfectly normal bladder. Do you get it? You get what I'm saying here? That we have to have different groups now. And I personally believe that the IC groups, the way they're being moderated right now, are hurting more people than helping more people. I do. Thank you, Frey. So please, please, please don't go to TikTok for IC information. If you are welcome to call me. I am a national expert in this. There's a phone. Feel free to call me. And if I don't know, I'll tell you I don't know. And I will send you to somebody else who I think might know. I'm not your doctor. I'm an educator. My job is to educate, inform, open up some new doors. You know, but the fundamental challenge here is that there's no path out of these dysfunctional groups right now. I mean, if we could have a conference for group leaders and teach them how to run groups, which I've tried to do over the years, because hello, I have a master's degree in this. So I just can't. And I will tell you, all my peers in all the other countries, everybody agrees that at this point in time, the online groups are causing a lot of harm right now. So just kind of take a step back, ground yourself with facts. If you have a question, feel free to call. Let's focus on really good factual information. Okay. All right. Sorry for my little rant at the end, but I couldn't believe what I was seeing. And I was just like, how can I report this? I want to report this. And I ended up pushing the buttons you need to push to make sure that patient got the support they needed. But shouldn't have been me. Should have been people who are moderators. So anyway. All right, guys. Hey, listen, we made it. It's 4:10 here in California. It's 7:10 on the East Coast. I'm very proud of you. You have dedicated some time today to learn more about IC and to improve your skills and to improve your knowledge level. Now you get to reward yourself. So how are you going to reward yourself? If you're out on the West Coast, let's go outside and enjoy the sunshine. If you're on the East Coast, you know what? Grab a good book, make some cookies, hang out with family, play a game, do something, take a long hot shower. Give yourself a reward. We're going to get through this together, my friends. All right. I will see you later. I'm going to say goodbye to YouTube first. Whoops.